very different. I'm sure everybody in the room who has HS is slightly different than everybody else. Like if you've seen one person with HS, you've seen one person with HS. So we do know it's a chronic condition, an inflammatory illness. You get extremely painful boil-like abscesses, and we go back and forth about, do we call them boils? Do we define abscess, nodule? And I'll kind of talk about what those words mean too. I'm not picky on what people want to call it. So if they want to say boils, that's fine. I think that's sort of like a common term that people get. But I also love when people learn some of the other terminology that we use. We talk about things like pustules, which is little pus bumps. Sometimes it looks like acne. That can be a part of HS, and we'll show a picture of that. You can get it anywhere that you have hair follicles. So you just, not on the palms, the soles, and the lips, but everywhere else, HS can show up. And as I'm sure all of you know, for different people, it does show up just about anywhere. Has a huge impact on our quality of life. And they actually did a study years ago where they looked at the impact on quality of life, and HS has as big an impact as cancer does to your life. Much bigger. It's like the biggest impact of all of our skin diseases, which is no surprise to any of us in the room. I put this cute little hydra. If you guys don't know the hydra, it is this mythological Greek creature that has multiple heads, and if you cut one head off, it grows two new ones. And hydradenitis kind of starts with hydra, so I draw the parallels there, that it's this like terrible monster with many heads, and you try to put it down and it tries to come back. But the reason I put this little cute guy here is those slides are going to have potential myths because it's a mythical creature. So I'll try to highlight some of those myths, because a lot of times what happens is there's certain data and science we have, but if you don't spread the message the right way, you're spreading myths and misinformation. So a lot of these things are the classic HS, typical, right? If you take everybody with it, on average, what does it look like? But that's why it's sort of myth too, because it doesn't apply to everybody. So usually shows up around the 20s, although I kind of think it's probably more often in the teens. People are just getting diagnosed in their 20s or 30s. But it can show up just about any age. There's even been cases of babies born with HS, or like shortly after birth. Very rare, luckily, but we're seeing more in adolescence. So it's one of those important messages that you don't want to say like, oh, you don't have HS because you're the wrong age. And you really don't want anyone to have that message for any of these typical features. It's like, oh, it's not HS. And we're trying to make sure doctors get that too, because sometimes that's the hurdle. Is I had some local docs be like, I think that looks like HS, but they're not the right patient type, so it can't be. And I'm like, no, it is. It is. It can be. We get those nodules, which are the bumps that are kind of solid, just a little ball of inflammation under your skin. The abscesses have a fluid pocket inside of them. So those are those ones that are incredibly painful, and you need to get that fluid out of there to relieve the pain. And then the tunnels are tunnels. We used to call them sinus tracts and fistulas, but those have these kind of complicated medical definitions, so we've just simplified it to tunnels, and that works a lot better. Of course, we see a lot of scars, and then comedones are blackheads. So one of the unique things with HS that we really don't see outside of HS is where you have the blackhead where it's one bump, but it's got like 2 or 3 openings. That's really specific to HS, and I say it's almost like a mini tunnel, because the big tunnels kind of look like that too. They're all connected underneath, and so those little tiny blackheads, so that can be a good clue for people, especially if they get those kind of earlier where you're not quite sure yet. It's most common in the fold areas, your armpits, your groin, around the genitals, the buttocks, but like we said, it can show up anywhere. So just because it's not showing up in those areas doesn't mean it's not HS. Pain is huge. Pain is the #1 symptom of HS. It's also the #1 reason that people engage with the healthcare system, because you try to take care of it by yourself as much as you can at home, and then the pain gets too much and you have to go get care. But we're recognizing way more the importance of itch in HS, and we're trying to even figure out, because a lot of people will say, oh, the itch is what, like the predictor of my flare. I start to get the itch and I know I'm going to flare up, or it's a clue for patients. But we, in the medical side of things and in the research side, have not been looking at it as much because we were so focused on the pain. And then, of course, drainage and odor. And then we call it chronic and recurrent. So it's a long-term disease, and it comes and goes, or flares up and calms down. Next slide. Here again, these are the stats, but don't let it become a myth where you're saying like women have HS and like all the things. They're not disqualifiers. So even though in the Western world, it's a 3-to-1 females. For every 3 females, there's 1 male. That still means a quarter of the patients are male, and it's not the same across the globe. In some Asian countries, there's actually more HS in men. And so we haven't figured that out yet, but it just speaks to there's something else influencing it here beyond just pure hormones. But we know hormones can play a role for a lot of people. Somewhere between 1% to 4% of the population, our estimates are not great because there's so many people who are undiagnosed all the time that we don't really know how much there is. And I think there's a lot more out there than we know about. And I'm sure as you guys do advocacy work, put the word out, people come out of the woodwork. One of my patients just last week or 2 weeks ago was like, I did a Facebook post and 3 people from my high school class reached out to me because they have it and haven't been diagnosed. And I was like, yeah, that's what happens. You talk about HS and all of a sudden people come up to you. I've had Uber drivers. I was giving a talk about HS at a conference, and when I got done and they went to take my mic off, the guy was crying at the AV booth. And I was like, are you okay? He goes, I have this. I had no idea what it is. This is I just learned so much from you. What do I do? And I was like, all right, let me hook you up. I know people in the area. We're going to get you taken care of. He's like, I literally have had this for 30 years and no one knew what it was. Next slide. I hope we're getting better at this, but our research hasn't shown us improving too much yet, but hopefully we reduce this delay. Most patients go years being undiagnosed where they don't see someone who knows what they have. And there's a lot of lack of awareness among doctors. Like they still haven't even heard of HS before. It's getting better. We're getting the word out. You guys are doing the awesome work of getting the word out. And honestly, it is one of the diseases where patients can self-diagnose very accurately. Like you figure out you have HS, and then you might have to go tell the doctor, I have HS, here's what it is, go learn a little bit, which hopefully will get better. Most people don't see a dermatologist right away. You're seeing your gynecologist, your pediatrician, your primary care, which makes sense because you're going to see them and then hopefully they recognize and refer. But we still have this delay of about 7 to 10 years. So hopefully it's getting better. And people, I always tell doctors this, patients aren't just staying at home. As you can see, in one of the studies, they saw 5 doctors across 17 visits. So a lot of like ER visits, urgent care visits, and none of those doctors knew what it was. So it's not like, it's like, oh, there's a delay because they're just not coming to see us. No, patients are coming to see us. The doctors just aren't seeing their HS. Next slide. Here's our hydra again. This is a little like more traditional picture of the hydra spitting some fire. So these are a lot of the big myths that we really try to squash. I'm very ashamed to say that doctors spread these myths often, and we're trying to get them better. So it is not caused by shaving or your deodorant or your antiperspirant. It's not from tight clothes or poor hygiene. I think everybody in the room knows patients with HS often shower more frequently than the average person because you're dealing with drainage and odor and leakage. It's not an infection and it's not contagious. That part gets really tricky. Even some doctors don't fully get that. And it's really weird because we use antibiotics to treat it. We'll talk on a couple slides about the antibiotics. Is it really the bacteria we're treating or do they have anti-inflammatory properties? But it's not contagious, not an infection. The reason it looks like an infection is it's the same part of your immune system. It's just attacking your hair follicles and your normal skin and treating it like it's infected. So that's why it looks so similar to an infection because it's basically like the same process. It's not from smoking. It's not an STI, it's not from obesity, it's not a weak immune system. Sometimes people get that misconception too, like, oh, I have this immune disease, my immune system isn't strong enough, and there's some herbs you can take to boost your immune system. But when you have an autoinflammatory condition like HS, that can make it worse because it's feeding the inflammation. And so sometimes that message gets a little bit mixed up and people hear like, oh, there's something wrong with my immune system, but they don't realize your immune system is like in overdrive. We gotta slow it down versus it's weak, we gotta boost it. That's where we talk about this autoinflammatory versus autoimmune. So technically the definition for an autoimmune disease is it's a disease where your immune system is attacking your body through a specific antibody. So like lupus is our classic example, and there's this lupus blood test where they measure the antibody levels in lupus. So that's autoimmune. Autoinflammatory is very similar. It's still your immune system attacking your own body, but in this case, there's just not a specific antibody. The beauty of there being specific antibodies is there's a really easy test that you can do to diagnose somebody, so I'm jealous. I wish it was autoimmune. Life would be easier. But it's autoinflammatory. But that one, I don't get too hung up if people mix those ones up. That's kind of like deep in the weeds. Definitely not a sweat gland disease. You'll hear that a lot, especially surgeons. We actually just did a research project that we're getting ready to publish, and we looked through textbooks of all the different medical specialties. And one of the surgery textbooks, the first sentence in the HS chapter was, HS is a chronic infection of the sweat glands. And so we told them chronic is the only word that is correct in that whole sentence. So we're working on that. Next slide. This is a really cool screening tool that they developed in one of the other countries in Europe where they can kind of like do population studies easier. But this just shows how easy it is to diagnose HS. Have you had outbreaks of boils during the last 6 months? Has it been more than one, and has it been in those high-risk areas? And if the answer is yes to both of those questions, there's a 96% chance you have HS. That's how easy it is to diagnose. So why are we doing so terrible is a lack of awareness. So many people still haven't heard of it. So awesome job going to Times Square and showing everybody what HS is, because they need to hear the term, they need to know, and it is improving and we're getting better at this. Next. This again highlights that there's the typical HS, but there's also atypical HS. So you can see in this picture, these are some buttocks that have more of a folliculitis type picture, but this patient still has HS. And so that can get really tricky for docs too when your HS doesn't look like the classic HS. You can also get the typical nodules, abscesses, but in atypical areas like your scalp, your neck, your thighs, other areas that are atypical. So this is a big one that we're always pushing on the docs, is to say there's typical HS and there's atypical HS, but they're both HS. Don't misdiagnose. Next slide. Here are some of the things that it is misdiagnosed as, and you'll notice in all of these pictures, they're close up. Because if people would step back and look at the whole patient, that's when you realize it's HS. When you just see one abscess, it might be a bacterial infection. But if you go, have you gotten these before? All of a sudden you clue into the fact that it's HS. And sadly, sometimes when you go to the emergency room, they're just focused on that one thing. Like, I just gotta drain this and get you out of here. And they don't put that picture together of, oh, I'm getting these more than once. It's a little sad. I was trying to figure out how do we help primary care recognize it, and we were going through all these different ways, like what questions can we ask, and finally I was like, just if somebody has more than one boil in their life, they should see a dermatologist. You can have one. One is a little infection, that's okay, but if you have it more than once, you should see a derm, and I'm hoping that simplified message will help people to get diagnosed earlier. Pilonidal sinus is interesting, this bottom left one. It's basically like the same as HS, but some people only get that. They just have a pilonidal cyst or sinus. It's usually right at the tailbone area, and then other people get it with their HS. So it's kind of the same disease. It's just a little different because you can have that only and not HS. Cellulitis is an infection, often misdiagnosed when people come in with HS, especially if it's really inflamed. Crohn's disease is an inflammatory bowel disease that can look just like HS, so especially if your HS ulcerates. It's a terrible term, but it's kind of accurate. We call them knife-cut ulcers because the shape of the ulcer, it looks like someone cut you with a knife, but it just opened up on its own. So that's one of our clues that it might be Crohn's. Luckily, a lot of the treatments overlap, and you can have both. You can have Crohn's and HS. They're called comorbidities, and we'll talk about those. Next slide. So pathophysiology is our fancy medical term for what causes a disease, what's the underlying cause. So I'll share with you some of the stuff we've learned about HS and sort of our current state and what we know. Next. This is the picture we always throw up at talks. This is where it's not a sweat gland disease, it's really a hair follicle disease. So we think the first step in HS where they take skin samples from people where they have HS, then they go next to it where they're going to have more flare-ups, but it's not there yet, and they find the hair follicles get a little bit blocked up. The skin cells that are supposed to keep them open block them up. Then you get a buildup of the oil that's normally around your hair follicle, and there's always bacteria living on us everywhere. But once they get trapped in there, they really grow and kind of go crazy. That ruptures, causes all this inflammation. But we'll talk about in a couple slides where we've now learned that HS kind of evolves as it gets more severe. And so at the beginning, the inflammation is really all around those hair follicles. And that's why for earlier patients, laser hair removal can be great. But later on, it doesn't help very much because once you get these tunnels, they have bacteria that line them. And then I'll show you in a couple slides all the inflammation that the tunnels really do change the disease. Next. This is another one that kind of shows the complexity of There's the hair follicle, there's the inflammation, and those are really at like the center of everything. But then there can be things in your life like friction from movement, stress. Smoking can cause it to flare up for some people. Hormones play a role, the bacteria, the skin barrier, so it's very complicated. Diet plays into this for some patients, but not for others. So it's a very complicated thing, and there's probably different types of HS. We just haven't figured it out yet to say like, oh, you have the type that's really hormone-based, and your hormones are really causing flaring, versus you have the type that is really scarring, but we're trying to figure it out. Next. These are really cool. So like, were we in Miami 2 years ago for the SHSA? When we were in Miami, these different groups are doing these genetic studies. So HS is a genetic disease. It's not a simple one like blue eyes, where if your parents both have blue eyes, you've got like a 50% chance that you're going to have blue eyes, or maybe 100. That's bad, I should know. But like eye color is really easy, right? Like depending, you can look at your parents and predict what you're going to get. HS isn't that easy, but they do these things called genome-wide association tests, where they just test your DNA and they look at, compared to people without HS, what areas of your genes look different. And they're finding these different genes, and the cool thing is the different groups that are doing it are finding the same ones. The ones that they're finding are involved with the hair follicle function and development, which makes sense for HS. The immune system and inflammation makes sense for HS. And then some that have to do with sort of scarring and healing. Because everyone asks, like, okay, HS, like if you get an infection, you get a boil, it ruptures, it heals. Why does HS turn into tunnels instead of just healing? And so it makes sense that these genes that we're finding kind of play out what we know about HS and make sense to us. They didn't find one that has to do with something that doesn't make any sense. So this is really exciting. Hopefully this will help us to then guide therapies, but I also find it empowering for some patients to be like, yes, this is a genetic disease. It's not simple like one gene, but it is genetic. Like that's why it runs in families in a third of patients, probably more than a third, but the research shows about 1 in 3 patients has a family member with HS. I think it's a lot more. Next. This is that one I was talking to you, and I know it's a kind of a crazy, complicated slide, but at the very top left are those tunnels, and then all those green and blue and purple things around them are the inflammatory cells, and there's so much around the tunnels that it looks like a lymph node, and our lymph nodes are normally full of inflammatory cells. You get a vaccine, you get an infection, your lymph nodes become the little factories for antibodies. HS tunnels have so much inflammation around them that they look like a lymph node. And that's why the disease changes when it advances. That's also why sometimes like patients will say, my medications were working okay, and then I had surgery, and all of a sudden they worked a lot better because they pulled out all that inflammation that the medications are struggling to handle. Next. This is the idea that HS is more than skin deep. There's things called comorbidities, and a comorbidity is if you have one disease, you're more likely to get other diseases. Not necessarily that the two cause each other, they might have sort of a common background, but just things that we see more frequently in people who have a certain disease are called a comorbidity. And there's a lot with HS, and we're learning a lot more. So some are mental health related, which makes perfect sense, but it makes sense 2 ways. One is HS is horrible to deal with, so that puts a strain on your mental health, but those inflammatory markers that are elevated actually affect your brain as well. So there's been some studies for people who don't have inflammatory disease, but they put them on anti-inflammatories and their depression gets better. Also things like metabolic syndrome, which is our combination of high blood pressure, diabetes, high cholesterol, obesity, and that is that stress state can make it harder to lose weight, easier to gain weight. It changes your metabolism. And then inflammatory bowel disease we mentioned, arthritis we're learning a lot more about, polycystic ovarian syndrome. I was actually just talking to Dr. Levtov out of Miami, and he was saying low back pain is huge. Like one of the studies showed 70% of people with HS have back pain, and we think it's just that inflammation that's just triggering, your whole body is inflamed. Next. Let's talk treatment. Next slide. This is the story I tell docs to say, and this is what I tell my patients often is, HS is like a house fire. We have medications and we have surgeries. The medications are like the firefighters. They got to come in and put out the fire, get rid of the inflammation. Then we assess the damage, and the surgeries are the carpenters who come in and repair the damage. It's a little more complicated than that, but it kind of gets to the point that we're going to combine things. I always say there's no one size fits all. There's not like an amazing drug that just works for everybody, so we're going to have to get to know your HS and what's going to work well. I always tell my patients, we're in this together. I'm glad you found me. Like, I'm not going to give up, because how many people have had a doctor throw their hands up and say, I don't know what else to do for you. I guess you'll have to see someone else. And then I always also mention that right now, combinations are very typical. It's rare that someone's on one medication and it's working perfect. It happens sometimes, and I love when it does. But often it's like, if this one gives you a partial improvement, we're going to keep it going and we're going to add to the regimen. And that's an important thing that I try to tell docs. You have to tell patients that, because it's not the paradigm for everything. And so you don't want the patient to come back and be like, all right, we need to change treatments. That didn't work. I'm not under control. It's like, well, are you better? Because then we'll add to the treatment and we'll build a regimen to get you under perfect control. Next. Also really important for people to know that if you start a medication and you have a flare-up, don't give up. You're going to have to pay attention to your flares. Are they less intense? Is there more good days in between the flare days? You know, that trend of like, it's flaring, now things are kind of calming down and getting better. And that's a really important thing when docs are starting medications, so patients know what to look for and know how to come back and say, is it working? Is it partially working? Am I moving in that right direction? But also really important that people know if you flare up, it doesn't mean it's not working. We're going to have to pay attention. Next. This is, we sort of break the treatments down. There's not only the medical and surgical, we also talk about lifestyle modification. That's the stuff that everybody's trying to figure out on their own. Like, does my diet change things? What kind of clothing is better or worse? What are all the things that just make me flare up or make me not flare up? So a lot of that you can do on your own, but places like HS Connect are phenomenal, because the resources through the website and through connecting with other people are just invaluable for helping you figure those things out, navigate them, and knowing which ones are safe. Because Brindley does an awesome job with HS Connect that we vet things and we make sure that they make sense with the science, and we don't post things. And the internet's great for people to share stuff, but it's nice when things are actually validated so that you don't get misled. Like, you know, sometimes people really are excited for something that worked for them and want to help people and don't realize the damage they do by saying, like, this worked for me, it's going to work for you, and then it doesn't work for you. And then, like I said, the medical therapies really target that inflammation, the redness, the swelling, the pain, hopefully the drainage, and hopefully prevents new spots. Then the surgeries target the chronic lesions, like that tunnel that just keeps draining, that little cyst that goes up and down all the time and flares up. And so that's a really important one that I emphasize to the docs, is when a patient comes back, you've got to ask those questions like, are you getting new spots, or is it your old spots that are bothering you? Because if it's the old spots, we probably need to do surgery, and if we change your medications, nothing's going to touch that. You just need surgery, but then you add on a little surgery to it, and all of a sudden you're under perfect control, not getting new spots, and the old ones are gone. Next slide. This is from, we just are in the process of updating our North American guidelines. So this is what's officially in the article. We are always careful to tell doctors that patients have had a difficult journey. A lot of people have told them they have it because they're smoking or because they're overweight or their diet isn't good. So you don't want to make people feel shamed or blamed. So we don't even bring these things up on the first visit. I'm like, no, let's build some trust. Later down on the road, I might say, hey, you know, are you still smoking? That's a healthy choice to stop. Let's talk about it. Let me help you out with it. But I'm not doing it right away because we've got to build the trust first. Next one. So here again, the little myth picture, because you don't want people to get the message that you have HS because you smoke. Lots of non-smokers have HS. Lots of people have HS and then start smoking as a coping mechanism too, because HS is just horrible. But we do know, the one thing I bring it up for is because the nicotine can actually be a problem. So with like the rise of vapes, maybe switching to a vape isn't as helpful. You know, like it still gets rid of some of the carcinogens, but the nicotine can actually cause your hair follicles to dysfunction. So ideally getting stuff off altogether, but if nicotine is a way to move that way, great. Next. Same thing. The studies are not great about weight management. We have a couple that show if you lose at least 15% of your body weight, it can be beneficial. There were some for bariatric surgery where some patients improved. There was one where they flared up afterward. And so it's a complicated picture, and like all treatments, it's different for everybody. Always great to have a healthy diet and to try to be at a healthy weight. But like we said, inflammation makes that more difficult. So we really want to make sure we're not sending a message of shaming and blaming people and saying that their obesity is a big factor in their HS. I've had a lot of patients who lose weight and it doesn't change their HS. I've even had some where it got worse when they lost weight. And so it's still a healthy lifestyle choice, and we're all working on it, right? But It's not like the holy grail, and it's not like, oh, if you lose weight, your HS will definitely get better. Next. This is a really cool article that Vivian Shi and Jenny Shao published. So if people, it was supposed to be animated, so that would pop up. But if you look up HS, Nutrition Education Toolbox for HS, it's not perfect, but it's sort of some simple dietary things that people can try. And you can see they simplify it to like healthy choices. Try to choose brown rice instead of white rice, whole grain bread instead of white bread. So it's very simple, and it's what we call open access. That means it's a medical journal, but anybody can get it. So if you just Google HS Education Toolkit or Nutrition Education Toolkit for HS, it'll pop up. And it's just like some basic stuff. I bring it up to docs a lot because we are terrible about talking about diet. Our education is not great about diet in medical school. So this at least simplifies it into something that they can do and be like, okay, read this handout, and then we'll talk about diet afterward. Next. HydroWare, love it, love it. So this is really important because I hope all patients can get access to HydroWare. There is insurance coverage, so go through the website, and if your doc, have them contact the team. It's tricky. Like, you guys have probably heard of prior authorizations for medications where the insurance literally looks for certain words. It has to say moderate to severe. It has to say this, has to say that. And the person who's approving it has no medical training. They just look for those words. They were given like a worksheet. So the same is true with wound care. So the team can really help the docs understand that you have to say you debrided it, you have to include measurements. They'll tell them the key things to get it approved, and luckily, it usually gets approved pretty well. It's fantastic. It's like the best wound care system ever invented for HS, and I hope everybody can get access. Next. Here's the Hurley staging. So the Hurley staging was invented by a surgeon, and it was a way to say who needs surgery. So Hurley stage 1, you have spots that come and go, but you're not yet getting scarring and tunnels. Hurley stage 2, you're getting scars and tunnels, but there's still some normal skin in between them. Hurley stage 3, the whole area is just full of HS. Your whole armpit is full. There's no more normal skin left. So it's all full of scar and HS. So we still use this because it's really simple, but it's important to know that this is not mild, moderate, severe. You can have severe Hurley stage 1 where you just have a lot of spots coming and going, but no tunnels yet. And there's actually a different system that they use more in Europe where if you have 5 spots ever at the same time, you've had 5 active HS spots, that's moderate disease. We're really pushing that for docs because we're waiting too long to start treatment. They're holding things back, letting people get scarring and tunneling, when really things are most effective if we start treatment before there's any tunnels. Next. And this speaks to that. So when we're teaching doctors now, we talk about this window of opportunity where the disease actually gets harder to treat when you get tunnel formation. The drugs don't work as well, and you usually have to combine them with surgery. So we're really pushing that we want people to get treated earlier on. As soon as they see any evidence of scarring and, heaven forbid, a tunnel starting to form, get it under control and turn the inflammation off. Next. This is, again, from the treatment guidelines where it kind of shows the medical stuff, the procedural stuff, and the flare-up treatments. Like I said, we're updating these. It's been an interesting process because people are really excited to have updated treatment guidelines for HS. At the same time, there's not a ton of super strong studies on treatments. So like the approved medications, we have really big studies with lots of people, but then like the surgeries, some of the recommendations that we come up with are, we have to say, like, weak or conditional recommendation just because they don't do the big studies on them, but it's just the nature of the disease. But it's still exciting to have treatment guidelines because it helps get things approved, help more reasonable approval process with insurances, although that's still a struggle. Next. Another way to break down the treatments is topicals, things that go on the skin. So a lot of times we use antibacterial washes. There's no studies to compare them, so some people like benzoyl peroxide, some like HibiCleanse, some like CLN wash, some like zinc, like Head & Shoulders shampoo. I always tell people, try them out, see what works for you. I know what my insurances will cover, so I usually prescribe one that's going to get covered to help eliminate some of the cost. We're doing, with Amit Garg now, a big cost study because we know HS is expensive. And then a lot of times we'll use a topical antibiotic called clindamycin. There was a study that showed it can be helpful for people, especially earlier on. I'm usually like, I don't know how well it's going to work, but it's simple, it's quick, and if it helps a little bit, it's worth it. If you have a side effect, we'll stop it. Otherwise, let's make sure we're throwing everything we can at it. We still use a lot of antibiotics, and that's where it gets confusing. It's not an infection, but a lot of antibiotics have anti-inflammatory properties. And in some sense, changing the bacteria that are on the skin might be beneficial. Some of the inflammation might be your body overreacting to these bacteria. We're still trying to figure it out, and I'm actually happy that now that we are getting more drugs to market, that we're moving away from antibiotics because they have a lot of other side effects. There was a study years ago in acne that showed if one person in the household was on antibiotics for their acne, all the family members who lived there had resistant bacteria living on their skin. So you don't just affect the patient, you're affecting the whole household because we all share our microbiome and our bacteria. So I'm excited that we're moving away from antibiotics and into things that are more safe. Hormonal things can include birth control or contraceptives. Spironolactone is a pill we use mostly in females because it sort of blocks the male hormones from affecting your skin. Metformin is actually a diabetes medication, but has some evidence it can help with HS. And then finasteride, we use it for hair loss and prostate issues. It's a hormonal treatment that you can use in men, women, and it's even been studied in adolescent girls. So it's kind of safe for everybody, but we're just kind of gaining momentum on using that one. And then the things that affect the immune system. So the biologics are the big one, and we'll talk about those. If your vitamin D is low, there's some studies that show getting your vitamin D back to normal can help your HS. I live in Michigan. Everybody's vitamin D is low. I just tell everybody take vitamin D. Next. So like I said, antibiotics, it's important to know it's not an infection. There's that, but bacteria may play some kind of role, probably that anti-inflammatory effect. Not all of them work. So because you've had a certain antibiotic and it didn't do anything and they gave it to you for 7 days, doesn't mean that maybe one of the other ones won't be helpful. I don't love them, but these are the ones that we reach for that actually have studies that can show that they work for HS. And like I said, I'm happy that we're sort of getting away from antibiotics because I think they're for infections. Let's get drugs that are for HS. Next. The hormonal things, like I said, spironolactone for females. Anybody can be treated with finasteride. Birth control that contains estrogen tends to be helpful. The ones that have more progesterone, because it's more of like a male-ish hormone or a masculinizing hormone, can flare it up. So I always tell docs, make sure you ask people, are you on the depot shot? Do you have a hormonal intrauterine device, IUD? Because those hormones can actually make your HS start flaring up. And I have a lot of patients who go, oh my gosh, since I started the depot shot, it has been a lot worse. And then we kind of work with their gynecologist and switch. Next one. This is a hot topic everywhere, are the GLP-1s. So this is like your Ozempic, your Wegovy, these medications that affect your hormonal pathways to make you feel less hungry and to sort of shift your body over into the I just ate mode even though you didn't just eat. And there's actually been 2 studies that showed they might be helpful for HS, and it might actually have some anti-inflammatory properties. They weren't super great studies. It was always like patients who have HS and are going to be started on one of these anyway, let's see what happens. So it's not a super well-controlled trial. Over 70% of the patients were also on a treatment for their HS. But I think this is an area where we're going to see more attention and more things coming up. I've had a few patients who improved. I did have one patient who started one and then her HS flared up, and so we ended up stopping it. So more to come on these, but everyone's very excited about these medications and what they're going to do and the role they're going to play. Next. So the ones that affect the immune system, I mentioned the vitamin D. There's been some studies on zinc that shows zinc supplement might be able to be helpful with HS. Again, not huge studies, but something to think about. And then our biologics. Accutane or isotretinoin is kind of questionable. There were some studies that showed it would help. I usually reach for it if you have bad acne with your HS, and I say, I'm doing it for your acne. I hope it will help the HS, but I don't reach for it for the HS alone very much because it doesn't seem to work super great. But like everything in HS, sometimes it does work great for somebody. And then our biologics. So the 3 that are currently approved are adalimumab or Humira, secukinumab or Cosentyx, and bimekizumab or Bimzelx. That's the brand names of them. So why are they biologics? Next slide. Biologics aren't like a chemical drug that we make in a lab. They actually have these like bacteria cultures and they put genes in them and they make them make these antibodies. So that's why they're so different. They don't interact with any other drugs because they're not actually a drug, they're an antibody. That's also why you can't take them by mouth because you'll just digest them. They're just protein. So you have to do an injection or an infusion for them to be effective. There are going to be some things coming out soon that are similar to biologics but are oral, which is kind of exciting. And they basically block parts of the immune system that are overactive in diseases. So as we figure out these things that are overactive, we can block them and then things get better. Next. This just shows another comparison, like aspirin, you can barely see that little green dot because it's so tiny, versus our biologics are very big. which doesn't mean a lot other than you can't take them by mouth. You have to inject them, and they work a little bit differently. It's also cool. It doesn't matter how well your liver or your kidney works because they're an antibody. So they're just protein in your blood like your natural antibodies. So that doesn't affect the dosing or anything like that. And the excretion of them is you just kind of break down the protein eventually. Next. This is Lauren Orenstein, who is at Emory, is doing the leader for HS pain and really advancing the field. We always say treating the HS helps with the pain to get it under control, but she's also doing studies to figure out pain. So there's acute pain, like when it's flared up, and then there's the chronic pain where it's gnawing and it's throbbing all the time. And she kind of went into how the two different types of pain work, but one of the cool things is there's this med called duloxetine, and it's actually sort of an antidepressant, but antidepressants work on your nerves. Pain comes from nerves, so that's probably why it works. It's not just acting like an antidepressant, but it's nice because it works for both of the types of chronic pain. So we're advancing the field and really trying to figure out and do better for HS pain. And you can see on the acute side, sometimes it's like you need to come in the office and I'm going to do an injection or do a de-roofing or help you out. So it's not always medical management of the pain. But I just put it up there to let you know that people are working on it, and we get that pain is a huge issue with HS, that it's just incredibly painful. Next. This is really also reassuring. One of my favorite phrases is there's never a good time to have HS, but this is the best time it's ever been. And literally, I can say that every day, and it's true, because there are 57 clinical trials right now going on for HS. They're in all these different phases along their pathway. Some are injectables, some are oral, some are topicals. One is acupuncture, wound care, surgery, all kinds of cool stuff, and 20 different mechanisms of action, like drugs that work differently. So it's really exciting that we're gonna have more treatment options. We're gonna figure out how to combine things, what's gonna work great for somebody. So there's a lot more coming out, and it's just a really exciting time that people finally give a crap about HS and are doing the work. Next. So I wanna wrap up with some resources that everyone can share with their patients and with the community and with the public. Clinicaltrials.gov is how you find those studies. So if you want to get involved, that's where you can go and look them up. It's actually pretty simple, where you just put in hidradenitis suppurativa and search for it, and you can say in my area, recruiting. But if patients also want more help with that, HS Connect is a huge resource. They can hook them up through HS Connect and the HS Foundation. We have a buddy program, so if someone's thinking about doing a research study and they want to talk to a patient who's been through it, they can connect and talk about it. And that's super helpful because research studies can be really scary. At the same time, they can get you access to amazing new medications that insurance doesn't even cover because they're not on the market yet. Next. This is through the HS Foundation. We have a great website. We have these research summaries where we take a research study, we translate it into language that anyone can understand. So this way, if people want to kind of stay up on research and keep an eye on things, you can go on here. We're constantly updating them and adding new ones, and we really try to pick articles that we think patients want to know about. So our most popular one is about HS and pregnancy, because that's something people go and they're looking for information on. So we have one on diet and what we know about. So we're trying to get things that it's the questions that people are wondering about. Let's show you the research and what it says. The next one is still from the HS Foundation. So this is our prior auth template letters. This is helpful for doctors and for patients to share with doctors. Is if you want any of these treatments for your HS, your insurance is going to say, show us the proof. They download this letter, and we put all the articles and all the research into them, so it makes it much easier for your doctor or their staff to get things approved because it's all just right there for them. So these are really great if you're trying to get something approved. You can say, hey, doc, you can get a prior auth template letter from the HS Foundation to help you with it. Next. This is the HS patient guide. So we wrote a textbook about HS, then we translated it into normal language instead of scientific jargon. It's free to everybody. It's at hspatientguide.com. We're going to update it because there's been some advances, but it's just a really great resource for the people who really want to get in deep and know more. It's kind of long. It's like a textbook, but it's got kind of everything we know about HS right now. Next. This is the Papaya app, which is free on all platforms. It connects to the HS patient guide, so if they don't remember that, they just want to do the app, that's totally fine. It has symptom trackers, medication tracking, so if you really want to pay attention to your HS. You can use the Papaya app to do it. And then when you go back to the doc, it shows it all in like one page. What has happened since your last visit? What were the ups and downs? What were your flares like? It's also really cool because on the back end, they have the data to then do some research from what we're gathering. It's sort of a way to like crowdsource the research and find out from patients like what meds are people on that are working well. And like I said, totally free. Next. And that's it. So happy to share things with you and happy to take questions. Suzanne.
Thank you. Just a general question on the smoking and obesity. Is that reported in other studies on other dermatosis, or do you just see it reported more in HS?
That's a very good point. It's just a general rule with inflammation. Smoking makes it worse. So like everything, rheumatoid arthritis, psoriasis, every disease, cigarettes just make it worse. So yeah, which is a really good point. It's not specific to HS. They're just generally bad for inflammation. And same thing with obesity. Our fat cells actually release pro-inflammatory chemicals that make you become more inflamed. So that's why like diabetes is worse if you're obese. Everything, rheumatoid arthritis, medications don't work as well, which is a really, really good point. It's not special. Like those smoking and obesity just are problems for everything, especially inflammation. You're right. There's not. They single it out a lot more in HS, and we actually just did an article that we published that surgeons sometimes go, I can't operate on you. You have to lose weight and stop smoking first. So we actually looked at all the studies, and there was no difference in surgical outcomes, whether you were a smoker or not, or whether you were normal weight, obese, or overweight. And so it's just this myth, and honestly, it's an excuse, right? Like they just don't want to treat HS. They just don't want to help people with HS. So they're like, any excuse to just like get rid of you, which is terrible and horrible. So that's why we published it, to be like, no, you have to stop saying this. This is not good medicine. And it's funny because there's definitely this sort of like bias of opinion, right? Where like we talk about it a lot in HS, but why don't we talk about it in psoriasis? Psoriasis is also associated with a higher risk of obesity, but we talk about it a lot less in psoriasis than we do HS. And I think it's just part of this. It's been so neglected for so many years. Finally, there are really great people involved, but there's still a ton of healthcare providers out there who are terrible with HS and spread these myths and misconceptions. And so it really is a good idea to like pull the focus away from these things. Yes.
Okay.
Oh, there we go.
So, kind of going off of Suzanne's like question, and this is like a question sort of statement, but I think where doctors use like the BMI, which is not 100% accurate for obesity. It's just not a battery because it's dying. So with BMI, like you can have more muscle on your body and have a high BMI, and we know that actually, and it was in Dr. Leptop's group did a study with HS patients and like resistance training, and the more muscle you have, your muscles actually have like the anti-inflammatory chemicals, right?
Yeah.
Combat that. So instead of focusing so much on like the scale, if you do some like resistance training with bands and you have more muscle on your body, so like how do we explain to doctors, or how can we get past the BMI thing, because like that calculation is outdated and debunked essentially, right? It wasn't meant to be for an individual.
Right. Yeah. So if you guys know, body mass index is your BMI, and you take your height and your weight, and there's this little formula, and then it categorizes you as underweight, normal weight, overweight, obese. You're right. BMI is terrible. I'm a kind of fit guy. I'm overweight by my BMI because I'm 5'7" and 160 pounds, and that's overweight. Yeah. And so the BMI is terrible, but we use it so much. And I think it's because it's simple, and then they just want to use it for research to like categorize people. So sometimes they'll use it for research studies to say like, okay, based on BMI, did the medication work differently? Did it work better for some people or better for others? But it's such an imperfect measure. And honestly, like dietary counseling, nutrition, exercise, we do not study them much in med school. They tell us like, just tell patients diet and exercise, and like that's the full extent of it. So that's why doctors are so terrible about talking about it, is because we just don't have the education. And I mean, med school is very busy. Like there's a lot to learn, right? And you have to learn all these medications. So then you don't learn as much about diet and exercise and like the actual truth behind everything, and muscle versus fat cells. So I think we've got a lot of work to do in those areas, and I am glad that we're moving toward it. Like, you know, like you said before, like 20 years ago, BMI was just accepted as like, oh, this is perfect. And now it's like, no, this is not perfect. This is not great. We need to get better about it. So hopefully.
We use them a lot, and society, they view their perfect image is basically a stick figure. Going back to GLP ones like Mounjaro, what are the others like?
Ozempic, Mounjaro, Wegovy.
Yeah, stuff like that. I went on that, and they were like, oh well, you're this and this weight. We're gonna expect you to lose like a certain percentage. So I went from like 220 to like 100 something, like 195, and they want me to go to like 130, and it's crazy what they want you to do and what their image is. 'Cause
Yeah.
nobody's perfect.
Right. And that's what like the ideal BMI is, like a very thin runner. Is like that's normal weight. And so like Krista said, like even just more muscle mass, all of a sudden you're categorized as overweight. So it's a very imperfect measure, and hopefully we'll keep moving the conversation and moving away from it. But it's hard because it's like a shortcut, right? Like people like something simple, height and weight. I can calculate this thing.
Okay, so I had a question about the biologics. So typically you're on like daily medication like spironolactone or metformin, but then sometimes you have to pair it with a biologic. So I'm curious to know, like, being on a biologic, they typically say about 6 months. Is that like definite? Are you able to go on it for 3 months and counteract that with the daily medication and see any progress, or do you have to go on for 6 months plus?
Great question. So I didn't show, but in the biologic studies and in most of the HS research, they usually check to see if something's working at either 3 or 4 months. But they keep working better after that. The reason they check at 3 or 4 months is because there's a group of people on placebo, which means fake medicine. So they're not getting it, and it's a progressive disease. So at that point, we go, okay, let's see if it's working. Now let's actually give these people the real medicine and switch over. You don't want them to stay on placebo for 6 months and get new tunnels that whole time. But they do tend to work better. 6 months is usually where they kind of level off. Like that's where you're at the peak. It's working as good as it will. Having said that, HS is super complicated. So like you said, the studies are just the biologic, usually by itself. Sometimes they'll allow antibiotics or washes. But in real life, I'm going to combine it with other things. And then we have all these treatment decisions to make of like, now I'm under good control. Can we take one of these things away or taper off one of these things? So it's a lot more complicated. And then there's even been a couple studies now showing what we all kind of knew is that sometimes you also have to combine it with surgery. So like I was saying, where the biologic got you here, but it's not going to touch that tunnel that keeps draining. No matter what I do, if I switch drug to drug to drug, nothing's going to touch that. But if I do surgery, so now we have a couple studies that show that too, that when you hit that peak and you stop getting better, check out those spots. Maybe they just need a little de-roofing or an excision, and then all of a sudden you're under way better control, which is what makes HS really complicated. Like in derm, we're spoiled now because psoriasis is so easy. You put someone on one of these biologics with psoriasis, they basically go back to having normal skin. It's so easy. Like it used to be hard when I was a resident. We would be doing all kinds of crazy treatments. We're going to get there with HS, but we're not there yet. And so that it makes it harder for docs to even understand that idea of like, so sometimes they'll put you on a biologic, and after 3 or 6 months, they're like, I don't think it's working well enough. Let's change. And I'm like, no. It's doing what it needs to. We just need to combine it with other things. So it makes it really tricky. Generally, the rule with biologics is if they work, you stay on them kind of for life. that's another tricky thing with HS is that it sort of changes throughout your life. So for some people, it does get better as you get older and like around menopause. For some women it improves, but not for everybody. And we used to really underestimate that. And there's been some newer studies. Also, it can show up later. There's this subtype that tends to show up in men in their 50s and 60s, and it's really bad around the genitals and the buttocks, and they like all need surgery. And we don't know why it does that. Like, why is it showing up now? So the management is really complicated with HS, and we're trying to get more and more experts and get the word out and help derms to be better, because sometimes you see someone who knows what they're doing, sometimes you see a derm and it's not great, and you got to find someone else who then does know what they're doing, and hopefully they at least recognize if they're not the best at it, and they have someone they can refer to. But we're trying to get everybody up to that level of being an expert and knowing what they're doing really well.
Just to piggyback off of exactly. Thank you. Just to kind of piggyback off of exactly what you were just talking about, I was going to ask about maybe, I mean, you're very knowledgeable about HS, of course, but as someone who's been dealing with it for 28 years, I can tell you that I've come across so many different doctors that didn't have a clue, but that wasn't relayed to me. It was more so like, seemed more like a prideful thing, like to
Confident ignorance.
yeah, just like no, I'm not gonna tell you I don't know what I'm doing,
Yeah.
but I'm gonna take you down this road as far as I can before I just let you know. And it got so much worse when I felt like, hey, if you would have just sent me down the street, or sent me to somebody that might have had a clue. Like if you knew from the start that you didn't know, like I feel
Yes.
like it's okay to tell me that.
Right.
So how is that like a discussion amongst doctors or residents when they start out, like, hey, it's okay to say I don't know, like I want to help you, but I just
Right.
don't know. Like, how is that a discussion?
It should be, right? And it varies so much. Like, part of it's individual with the doc. Like, some are just super confident that they are awesome and they are gods and they know what they're doing, and they don't. Others, like you said, it is that sort of a fear, like the patient's here. I want to convey that I know what I'm doing and that I'm going to help you. And some just like aren't up on the research and on how to treat it. Like sometimes you see a surgeon who goes, yeah, just you have to wait till it gets worse. There's no treatments for it, but when it gets bad enough, we'll cut it out. And we're like, no, there are treatments. Like, get up to date, which is sort of a bigger problem with our healthcare system in general, is that you have to do this continuing education as a doc, but you get to pick what talks you go to and what meetings you go to. So there could be something you're really bad at and you never get better at it. And that's where like there's an opportunity to empower patients. Like I've talked with Joey Torre before about like, how do you find a good doctor? What does that mean? And it's hard because you sort of assume they know what they're talking about. And if they come off real confident, even though they're saying everything wrong, how are you supposed to know? So that's where a lot of like these conversations, the awareness can be really good to bust some of these myths. So if a patient goes to a doctor who's like, oh, we just need to cut out all your sweat glands, instantly you're like, you just said cut out the sweat glands. That means you are not up to date.
Right.
Yeah, you are outdated. That wrong.
Yeah. Okay, we are out of time for questions. Thank you so much, Dr. Dave Louie. We have a quick 10-minute break, and then we are back with surgical options with Dr. Goldberg. So get some water, go to the restroom, and you can come grab him and purse him and corner him if you want to ask more.
Oh, yeah.
So yeah, let's get into it. Dr. Goldberg. Hello.
Do I need to? Okay, hi. This is so fancy. I get a little clicker that goes on my finger, and I'm going to do a couple things. I am going to set an alarm for 30 minutes because I want to give some time for some fun. And I'm going to lower this. Can I lower this so it's not in my face? You can also have a handheld if you'd rather. You want a handheld? Oh, yeah, I'll take a handheld. If you, oh, here. Oh, yeah. I'm very needy. I'm sorry.
No, I think these are louder.
Okay. All right, and I have my slides right here, just so I don't have to. I can look at you. Hi, and oh, sorry. Hi. How's everybody feeling? Awesome. Well, I had a great time with Dr. Dave Louie's talk, and I thought it was really informative and a lot of really important information and I will try not to duplicate it. Hello to everybody online. Very happy that you're here to join us. What I hope to do today is give you a little information about surgery and make it a little less scary. And hopefully you'll see it as an amazing tool that could have significant value to you or your loved ones who have HS. So let me start by getting a tempo of the room. Who thinks surgery is scary? All right, so I would say we actually have a lot of open minds in the room who don't think surgery is scary, so that's a good place to be. Surgery, well, a couple things. First of all, I'm a surgeon, and I do specialize in HS surgery. I became interested in this space when I felt that the techniques that we were doing and we were taught about in surgery were frankly barbaric and didn't really account for the disease. And over the last 10 or so years, as we've learned more about the disease, and we've busted all these myths about the disease, we've figured out just that. There's a lot of other opportunities out there for surgery which can be more effective. So hopefully I'll walk you through some of those things. I also oversee education at my healthcare system, which is Mary Washington Healthcare in Fredericksburg, Virginia. We're about 45 minutes south of Washington, D.C., and 45 minutes north of Richmond, Virginia, centrally located. And I love education, I love teaching, so please feel free, and frankly, I want this to be for you. So you are welcome to interrupt me at any time if you do have a question that's fairly pressing, because I'd rather answer your questions and help you understand and get what you need out of this conversation. And I can already see that I'm gonna have trouble moving my slides. Okay. Disclosures, I like to say I cut people for a living. I am going to ask, actually, yeah, and teach people for a living, and so that's a good thing. There are pictures that are on this presentation. I have permission from patients to show them. However, I am going to ask that I know you'll all be respectful of them, and please not reproduce any of this material. So Dr. Dave Louie talked a little bit about the different approaches to management of HS, and I view these as the three pillars: medical, surgical, and lifestyle modification. And surgery has had a bad reputation for some time. And the reason that surgery had a bad reputation is, do you know years ago, dermatologists didn't treat this condition. This was really only managed in the surgical space. It was actually treated similar to tertiary syphilis, okay? And now you can kind of see in your head some of these myths that have been perpetuated over the years. And the treatment for tertiary syphilis was to cut it out, so that's what happened. Well, lo and behold, what happened with all of this was that the recurrence rates were high with cutting it out. It's because we didn't understand a lot, and those weren't necessarily in isolation. Surgery, for some people, it can be a great tool in isolation, but for most people, we need all of those other additional therapies to help manage it. And that includes the medical management and then the lifestyle modification. So if we look at this model, it takes a lot of different partners to put our brains together to figure out what the best treatment option is. And it's going to differ for everybody. So one person's experience with surgery may be different than another person's experience with surgery, and we have to remember that. But the partners in this are going to be the dermatologists on the medical side, the surgeons on the surgical side, if there's surgical, if that's something that you might be interested in, and then patients, you all. You all are an important driver. In fact, you're the most important driver of what your care plan and your treatment plan is going to look like. So please never forget that. Everyone's HS is different, okay? And when people talk about their HS, unless you've seen what it looks like, and not only seen what they look like, but understand how it impacts their life, it's like comparing apples to oranges in a way. So keep that in mind. And when you show up at your surgeon's office, at your physician's office, when you're trying to articulate it, the biggest piece of advice I can give is to really focus on the quality of life piece, because it adds another dimension to what the physician is seeing. When I'm seeing things and I'm helping you all come up with a surgical plan, I've learned that it's not just about what I'm seeing. What I'm seeing will help guide me as far as what the different options I have in my toolkit to provide you with. But the right option that we choose is going to depend on what your goals are for surgery, and we'll talk about that in a little bit. So the next thing I want to talk about is what's happening below the skin is not necessarily what you see. And this can, to the naked eye, and that can also make it very challenging to help come up with what the right or the correct pathway for surgery is. So you can have normal appearing skin, and normal is not the right word, I apologize. You can have skin that does not look like it's affected, okay? But underneath it, there's a lot of disease. So what does that mean for me as a surgeon? What it means is that when I get in there, I may find more disease than I anticipated. And my initial, when a surgeon goes into the operating room or the clinic to do a procedure, we have a roadmap in our head of what we're going to do. But it's kind of a new discovery when we get in there, and we may do different things than what we find. So what that means is that the trust that you have with your surgeon is going to be really, really important, because you may be asleep undergoing surgery, and the surgeons may have to make some decisions of which route to go and what would be important for you. And that's why that goal setting up front of what you're looking to get out of it and the trust that you have in your surgeon is going to be even that more important. Dr. Dave Louie talked about the different things that happen under the skin. And when I'm in the operating room, the things that I see are the hard, painful, inflammatory nodules, the small pockets of a jelly is the best way to put it, and then what I like to call the gelatinous material, or the gelatinous, what was the word we used to use, Brinley? I'm trying to remember. It was really funny, and it's not coming to me now, but we had an endearing term for it. But tunnels lined with the jelly, and what we find is once we remove that jelly, everything, it takes care of that inflammatory process in that area, which allows the tunnels to heal, and that's amazing. A lot of times I see a lot of scar that's mixed in with the tunnels and the gelatinous material. So what is scar? Scar is actually your body trying to heal. It's your body recognizing that something's going on, and it's fighting, it's trying to heal, but a lot of times it can't heal everything. So is scar a bad thing? Scar by itself is not bad. It shows that your body is reacting to it. Scar combined with some of the disease in the middle is when you develop those flaring scars and that's something that is very helpful to remove. But scar by itself, as long as it's just scar, I don't feel that I necessarily have to remove that unless there's a reason where it's impacting your quality of life. All right. Next. Oops. Okay, here we go. So what is HS surgery? And this is an important question, because if I ask each of you in this room, or even all of the patients who I've partnered with, everyone would give you a completely different answer, okay? And you'll hear people say, I've had 27 surgeries. Well, if you hear that someone's had 27 surgeries, what is your perspective of surgery gonna be? And they're still having challenges from HS. You're gonna say, I'm out. I'm not doing this. Surgery doesn't work. So again, with the idea of keeping an open mind, I want you to understand the basic procedures that are included in that pot of HS surgery, so that you can contextualize all of these things. So, and it's actually really, really basic when we think about it. So I'm going to break it down. The first thing is incision and drainage. Okay, so incision and drainage is a procedure. It's often used in the management of acute flares. If you have something hard underneath the skin with no fluid or no abscess, you can't incise and drain it. In fact, many of you may have gone to the emergency room or the primary care office, or even sometimes the dermatology or surgeon's office, because sometimes it's hard to tell. And they cut into it and they're like, there's nothing here to drain, okay? So some things are amenable to drainage with HS and some are not amenable to drainage. But incision and drainage is really, really controversial. So why is it controversial? Well, if there's fluid inside and you release the fluid inside, what it's gonna do is it might give you a lot of instant relief on the pain and the pressure. But guess what the recurrence rate is? 100%, or nearly 100%. That's what I like to say, because nothing is because nothing's 100%, right? In life. I'm sorry, I'm pulling back up my slides. Okay, my computer's set to go off. So the challenge there is actually it can improve your quality of life or worsen your quality of life, because you have this well-defined cavity underneath. You have all of the inflammatory material that's driving this process. And what I see far too often is that you can turn what was a closed wound by opening it up into a chronic draining wound. So what we've done is we've relieved the pain, immediate pain, and now we've added another dimension towards quality of life and impacting quality of life, because now you got this chronic draining wound that just won't stop, and there's the need for bandages and dressings, and there may be that odor that can just be a lot to manage. So in the patient advocacy world, there are very strong feelings about whether or not to do incision and drainage. What I'm going to tell you is that it is a personal decision. I can't say in the field it's wrong, because it is a tool, but I don't think it's going to give you the long-term goal of what you're looking for. And there's so many different options that are out there available to you that we'll discuss, that my suggestion would be to go to one of the more definitive options that may be more helpful for you. And on that note, I do want to pause just to be respectful to Brinley. Is there anything else you want to add there about incision and drainage?
No, you're right on. In the patient advocacy world, it does provide immediate relief, but then can cause longer-term issues, and the rate of recurrence is nearly 100%. Yeah.
Okay. All right. Thank you. I just wanted to make sure that I was giving, a good message that really resonates with everything else. Okay. So any questions about incision and drainage? All right. So that's one modality. Let's move on to excision. So what is excision? We cut it out. You just go down, you go in and you literally draw a picture and sometimes you even can use a special marker, skin marker that comes off, and you literally cut it out and it goes down to the subcutaneous tissue and it leaves a hole. And we're not going to talk, right, for the purposes of what we're talking about now, we're not going to talk about any of the closures, the wound cares, things like that. We'll get to that later, okay? So what's the challenge with excision? The challenge with excision is that as we've come to understand this disease a bit more, what we find and what we know is that the skin that is unaffected around the disease and the tunneling and around the inflammatory area still has changes that you can't see. It has HS. We know that HS, and when I say HS, we know that this is a disease that runs deep through the body, that it's a systemic inflammatory disease. So what we call the perilesional skin, or the skin around the lesions, still has transcriptomic changes, meaning changes and that propensity to develop HS. The other thing is that our eyes can only see so much. So you may very well have microscopic changes that are not visible to the naked eye around that skin. So if you have excisional surgery and you get more disease in the area, is that a failure? Is it a recurrence? Does it mean surgery doesn't work? No. It actually means that it is it's expected. It could very well happen. Now, I will give one caveat to all of this. Excisional surgery, and it doesn't mean that, again, that excisional surgery is wrong, because we have to talk about why are we doing the surgery and what are we looking to get out of the surgery. We'll come back to that. But going back to the different anatomic regions of the body, for one reason or another that we don't understand yet, different surgeries behave differently, and disease behaves differently in different places. In the armpits, for the most part, if you cut it out in the armpits, it typically does not come back in the armpits. So it's a great procedure for those areas. In the other areas, what are the challenges with some of the excisional surgery? Well, you're cutting down to the fat. And since you're cutting down for the fat, you're taking out a lot, and everybody has fat. Even Dr. Dave Louie has fat. Despite his abnormally elevated BMI, okay? For his 5'7" and 160-pound body habitus. But you're going down to that subcutaneous tissue. It's going to leave a defect. Most of them actually heal up pretty well, but in some of the large areas, like think about your backside, if you cut out a chunk of your butt, you're cutting out a chunk of your butt. So what does that mean for when you sit down? And these are things to consider. Any questions about excision? Okay, and I'm having a hard time looking backwards, so just keep bearing with me while I go. So the other piece of this, and I don't know why my slide isn't projecting, but is de-roofing. So don't focus on this right now, and focus on me instead for a second. So what is de-roofing? De-roofing is where, instead of going around the disease and drawing a circle around it, we're going to go straight into it. And we're going to basically, there's a tunnel or a cavity, and we're going to open it up and literally cut right into it like we were doing an incision and drainage. But here's the difference. We're going to get rid of all the stuff that's lining that cavity that's causing the problem so that it can heal. And what are the benefits of this? It heals really, really, really well, and we take less tissue. And what the other fun part of this, which I love seeing, is that as you take that out, you take less, all of the inflammation surrounding the area just melts away. So you actually don't have to take out as much tissue, and it's really easy, and it's not as deep. And I'm going to show you all later on some candy and let you do your own de-roofings on candy. Anyone can do a de-roofing. It's really, it's not hard. Please don't try it. I'm sorry, when I say anyone can do it. Thank you. Yes. Oh, Dear God, Dr. Goldberg says go home and do de-roofing. No. But I will say that, so I learned this from the dermatologist. And that's one of the challenges with HS surgery is that this is something that's not taught to surgeons. So what I've done is I've been able to say, okay, instead of doing this in the office, I'm going to do this in the operating room. And I'm going to spend a couple hours chasing all these interconnected tunnels, all the heads of the monster, the Hydra monster that Dr. Dave Louie talked about, and hopefully get you a much better outcome than if we excised it alone. So it's a very exciting thing. All right, so what instruments are used to perform surgery? And the reason, let me do a time check. The reason that this is important is because you're gonna see a lot of ads for different things. And you're gonna say, oh my God, well, do I need CO2 laser? Do I need de-roofing? Do I need this? Do I need that? If you go back to those 3 procedures that I spoke about, and we're actually gonna say 2 because we're gonna drop incision and drainage, there's only 2 types of procedures. There's de-roofing and there's excision, applied in different ways. Sometimes I even combine them. And what I'm gonna tell you is that they can be done with any different type of instrument and tool. So do you need CO2 laser? No, you don't need CO2 laser. Are there people who have the CO2 laser and use it as a modality? Absolutely. Can you get the same effect with other tools that surgeons have, whether it's scissors, whether it's a scalpel, whether it's electrocautery device? Absolutely. So please don't get hung up on that. Everybody has access to different resources, and what's more important is for you to figure out whether the excision or the de-roofing or a combined technique is better for you. All right, so how does it heal? Well, if we go back to the old literature, we used to close everything, all the surgeons, because surgeons have this theory of have wound should close, okay, that you can't walk out. Well, the dermatologists have taught us that these wounds heal really, really well. If there's anything that HS patients are well, you're amazing at a lot of things, but you are rock stars at wound healing. So own it and be proud, okay? So what we've also found, and why, is that when you close these wounds, there's a good chance that they might fall apart, they could get infected, or you could recur. And when you recur along the incision line, because you've created this space, which is sometimes larger than the original disease, it can create more challenges for you. Now, there's many people who've had really good outcomes with closures. So it doesn't mean, again, that closure is wrong. It comes down to, is it the right thing for you? What are the risks? What are you willing to accept or not accept as you make your decisions with what that after surgery care will look like and what the different outcomes could be in optimizing that? But I can tell you that Dr. Dave Louie and I, we are firm believers in secondary intention and healing. So what does this mean? You go home with a wound, and it takes longer to heal, but let me tell you, the outcomes are extraordinary. And although, especially for a big area of the body, it can take 3 to 4 months, or even sometimes 5 to 6 months to heal, the hard part is really the first 2 to 3 weeks. And when I say hard part, a lot of it is more psychological than anything, because the reality is you get home and you say, holy crap, what the hell did she do to me? And you say, is this thing gonna heal? This is never gonna heal. And it's scary and it's frightening. But one of the things that I found that's really helpful after surgery is I sit down with family members or whoever is going to be your primary caregiver helping you through this process. And we, with your permission, review close-up pictures of the before and close-up pictures of the after. And we talk about what you're going to do, and we make it less scary. And if it is scary, we'll have you come back after 2 days, and we'll guide you through the wound care process. And I have an amazing nurse, shout out to Jennifer Simmons, who is a pro at this, and she'll walk you through it on the phone too if need be. So don't let that frighten you. And the reality is that the downtime for these procedures, even big procedures, it's typically only a couple of weeks, because guess what? You have no restrictions. When you have something that's not closed, you can go out and you can go back to work, you can do whatever you want to do, and you are not going to hurt it. So just as many of you are walking around with chronic wounds, now, after surgery, you have a wound that you can walk around with that's in the healing process. And it's really fun for patients to watch the healing process and see just what wound healing rock stars you all are. So what does the wound care look like for secondary intention healing? Same thing, there's a couple of different ways to do it. And a lot of it is going to depend on what resources are available for you. I'm going to tell you what's not going to work. What's not going to work is wound care dressings that you can't afford or can't pay for. And these advanced wound care dressings can be a lot of money. And you're not going to heal any better with one or the other. Everybody heals at a different rate. It's not scripted. Sometimes wounds need a little extra love, and there's a couple of different ways to do this. So my approach is, if your insurance covers the wound care products that I love, that's great. And if it doesn't cover the wound care products, I don't want you going out and spending money. We're going to find a plan B, because in life, I tell my children there's always a plan B, and it's going to work just fine, and it's going to heal just fine. So we're going to figure out what resources you have available to you. If you have no one to help you with your wound care at home, we're going to figure out another plan for how to do it. And let me tell you, I have people who have managed, obviously I can't share their names, but I literally had this one gentleman a dear patient, who has this big buttock wound, probably like this big. And he's managing it himself. And finally, when he came back to the clinic about a month ago, I said, okay, you got to show me how you're doing this. And literally, he has this process. He lays it out, and damn, does he do a good job. So we'll figure it out is the short answer. Okay, and I'm down to 3 minutes, so I talk. That's just the way I go. Does the wound get infected? Which I know is a big question for everybody. Here's a little secret. We leave wounds open so they don't get infected. When we leave wounds open, they don't get infected. Sometimes they need a little extra love. Sometimes they need a little bit, or it's very rare. Sometimes they develop like a film on top that we have to gently remove and there's lots of different ways we can remove it. Sometimes painless, sometimes with a little bit of rubbing, which is typically not too uncomfortable compared to everything else that you've been through. But they actually do better, and there's less risk of infection if we leave them open. Does it hurt? Well, pain, as Dr. Dave Lewis spoke about, is a very, very complex thing that we still don't fully understand. There's physiologic pain, and with the physiologic side, there's different types of pain there. There's also, we know that our psychology, our mental health can impact our pain. So we try to address these in a multimodal fashion, but the reality is that, and I can show you videos, most people do not experience a lot of pain from this. And I'll tell you one of my favorite things is, if you have pain right now, that gnawing, deep-seated pain, which I can't tell you what it is because I've never had it before. However, I've had people describe it to me. When you wake up from surgery, the first thing I say to people are, how is your HS pain? And they say, it's gone. Now, it might be replaced by discomfort or a different type of pain, but you know that pain's gonna get better over time. So it's really, really exciting. All right, I'm gonna skip ahead a little bit just in the interest of time. All right, so when you see a surgeon, knowing that it's not a one-size-fits-all, what is the most important thing that you can do when you walk in the door? You have to set expectations, okay? So you have to walk in and you say, I am coming to you to discuss surgical options. Here is what I want to get out of surgery. Can you do this for me? And everybody may have a completely different goal of surgery, and that is okay, okay? So is your goal to a cure? Well, I would urge you to stay away from that question, because we know that this is a systemic disease. And if you have a surgeon who says to you, this is a cure 100%, it means that they probably don't understand the disease. Have people had surgery and not had any issues? Absolutely. But it doesn't mean that their body still isn't primed with that underlying systemic inflammatory process, and that they certainly could develop disease at a further time. So I love one day we will have a cure, but right now we're not quite there yet. So to me, it's a red flag or a warning sign if someone tries to offer you a cure, with the exception of under the armpits. Because again, for one reason or another, we know that complete excisional surgery on the armpits tends to work really, really, really well. But is your goal, that's my timer, okay. Is your goal to decrease pain? Is it to decrease drainage? Is it decreasing flares, less isolation, relationships, feeling more confident, return to work? Those are the things that you have to decide what's important to you, and you have to inform it. And similarly, when we talk about the different types of surgeries, and it's not a one-size-fits-all, what I like to tell people is we have options. We can take a minimalist approach. We can take a maximalist approach. You might not have the luxury of taking time off of work. And if you don't have the luxury of taking time off of work, the maximalist approach may not work for you. So what we have to figure out is how to do it in a different way. So one of the first questions I always ask people is, what do you do for work? Does your work know about this? And who do you live with? And that gives me a framework for trying to customize and tailor what could be best for you, combined with the goals that you're looking for, so that we can set those realistic expectations. All right, so who performs HS surgery? It's a myth that you need a plastic surgeon or a colorectal surgeon or a general surgeon or a trauma surgeon or a dermatologic surgeon. You need a surgeon who understands HS, and if they don't understand HS, they're willing to learn, either from someone who understands it or educate themselves through this kind of space. So please don't get hung up on necessarily what type of surgeon you're going to, and that you may have better outcomes from one specific type of surgeon. Find someone who's knowledgeable or willing to learn and will listen to you, and that will give you the best outcomes. How much does surgery cost? It is also a myth that insurance does not cover HS surgery, okay? So if you are being charged out of pocket, like purely out of pocket, and they say HS surgery is not covered by insurance, I'm not talking about copays or deductibles or things like that, that is not true, okay? I have never had to have a patient pay out of pocket for a surgery. Most of the time, if you're even out of network, we can work with insurance companies to get it covered, because there aren't many people who truly understand and do this type of surgery, and or if that's not an option to them, or if someone doesn't have insurance and does have to pay out of pocket, there's certainly the option to look at payment plans and things like that. But again, this should be accessible to you and never break the bank. When is the best time to have surgery? Anytime. Everybody is a candidate for surgery. I love for patients to be optimized on biologics. And I do think that the combination of medical management, surgical management, and lifestyle modification is the best. And we have those conversations. But sometimes access to biologics can be very, very difficult. So there are still things that we can do. So let's have those conversations. Let's talk about it. But don't feel, surgery can play a role. It can play a role for everybody. So let's use this as a tool in our broader decision making. Dr. Dave Louis spoke about optimizing preoperatively using medicine. and that's really important. And he spoke about different things that we use to help control inflammation in general. It's the same things that we use to help optimize you preoperatively. A lot of these things are just good health things overall. So absolutely go ahead and embark on that journey. It's going to help, not hurt. So I've talked about this. What makes the surgical procedure successful? First thing is a partnership built on trust. And I'll be honest, if a patient comes to me and I sense that they're uncomfortable or they're not fully in it, I say, you know what, I don't think this is the right time. Or, you know what, come back again. We don't have to rush into anything. Let's have some more conversations, because I want you to be as comfortable with this as I am with this, and we need to have this strong relationship in a bi-directional fashion. Plus, I want to celebrate all of your successes with you. All right, I'm gonna stop there, and I'm gonna do a little demonstration. But before I do that, I'm gonna ask if you have any questions. Nothing? You what? All right. Would you grab me that open box?
When you were referencing, people who say a cure, and I mean, I know there's some surgeons, were you talking about Dr. Tahir?
I'm not referring to any doctors whatsoever. What I'm talking about is an old myth that this is a surgical disease of the sweat glands, which can be cured by removing the tissue.
Right. How do you, would you recommend if someone, you mentioned like certain red flags, and I think Dr. David Louis also mentioned that. How do you recommend a patient start that conversation, or should they just I'll see myself out and shop around if they those red flags are thrown up, like the cure word or the sweat gland removal word?
So that's a great question, because the reality is that a lot of surgeons don't want to treat this. So you got to find someone who wants to treat this. Don't waste your time. Don't waste your copays. So when you call to schedule an appointment, one of the first things you want to ask is the office staff is, does this doctor or physician do surgery for hidradenitis suppurativa? That will save you a lot of headache. And you still don't know what their level of understanding and knowledge and what they're going to offer you is, but if the answer is no, let them tell you right away so that you don't have to show up and waste your time. And there's enough burden overall on your time, so let's make sure that we get you to the right spaces. Even within the surgeons, amongst the surgeons who specialize for HS, there are different understandings of the disease and different approaches that they have. So also don't be shy in getting a second opinion. That's not a bad thing. Better to do that again and feel comfortable with everything than not. And then when you're in seeing a doctor, I think you can also ask them about what I call complex deroofing, or deroofings versus excisions. If they don't know what deroofings is, to me that's another flag. Or if they can't give you a good reason why you don't qualify for a deroofing, that might be another flag in my head that maybe I need to look around a little more.
I was just wondering about the different types of healing. I know you said secondary intention, but I've also heard about skin grafts, there's wound vacs. Can you talk a little bit about the advantages or disadvantages of just leaving it open versus closing it with a skin graft or using a wound vac?
So I have lots of slides on that, which I didn't get to just in the interest of time. So I'm also happy to review all of those with anyone who would like to during the lunchtime. But the long and the short of it is that it's this. I spoke a little bit about why we've moved away from primary closure. The other way, for if you have a wound that's open, there's a couple of different other modalities that you can use. One, of course, is to do a skin graft. But you still need to get a good, what we call a base of tissue, healing tissue, and go back to the operating room to do a skin graft. The benefits of the skin graft is that it typically can take about 6 weeks to a couple months to get to the point of being able to do a skin graft. Another procedure under anesthesia, you're taking skin from another area of the body. If you have other types of acneiform disease or so forth, or even a phenotype of HS where you have disease on other parts of your body, it may limit where we can take the skin. It is incredibly, incredibly painful, and there's a chance that the skin graft won't take. And then all is for naught. Actually, not all is not for naught, because typically even there's some microscopic cells that you can't see that help facilitate the healing. But what we found is we can do it without this. So that is certainly an option, but what I have found is that the cosmetic results and the degree of people seem to be happier with the cosmetic result of the wound contracting on its own rather than just having a big wound with the skin graft on top. Because when a skin graft goes on, it doesn't look the same as what it would look like if your body just healed. And even though a wound might be about this big, and I'll have, again, happy to show you pictures afterwards, it'll shrink down to a line for the most part. It's pretty amazing. So that's one option. The other option is a flap. And I will share, I am anti-flap. And I know, and I've done, mind you, when I started out my journey as a surgeon dealing with this, or addressing this disease, I would admit patients to the hospital for 3 months at a time. We even had parties. I have, shout out to two of my favorite teens from years ago who now have kids, which is crazy. But I still remember admitting them to the hospital to have surgery, and we had parties when I was on call where we ordered wings and mac and cheese. They chose their food of choice. They became fast friends and celebrated. I have another couple of special ladies, you know who you are if you're listening. Same thing, admitted to the hospital. They had colostomy bags, which I never do anymore. Went back and forth to the operating room every other day for about 2 months. We skin grafted them, and we don't need to do that anymore. So, sorry, where did I go? So that being said, wound vacs. Wound vac is another way to manage an open wound. And wound vacs are a personal preference that I discuss with patients. Now we have home wound vacs that you can take home. So where are the barriers with that? Or actually, where are the pros? The pros are that the studies show that wound healing can occur a little more rapidly than without it. Is it the be-all and end-all where you absolutely need this for the wound to heal? Absolutely not. But it is a tool in the toolkit that we can use for you if you'd like. What are the downsides of it? The downsides are it can cause a lot of pain in people. The nurse does come out to the house typically 3 times a week, assuming your insurance will cover that, a home health nurse, who will change the dressing for you. A lot of people with HS have some irritation to various different adhesives, and the adhesive from the wound vac can also be very reactive, or people can react to it who have HS, so that's another potential downside. And then the other piece is this. You get a purse or a MRS. You know, remember the MRS male purse? Okay. So it comes in a bag. The machine comes in a bag. There's a humming noise. It's not silent. And it's a matter of, is this something that you want? So if this works for you, or say you're not comfortable with the wound care, or you would prefer that model, let's do it. But it's not a must-have. It's a tool in the toolkit that we can use. And then I apologize because I realize I went all over this place. Let me come back to the flap question. So we used to do plenty of flaps, but here's the, I've seen the published studies, and I know that some people do flaps. Flaps seem to work the best under the armpit for the same reason that I said that it doesn't tend to occur under the armpit, and we don't know why. A flap is a big operation. Do you need to do that? No. And if you see the results of what happens if you just let an axilla heal by secondary intention, it's a beautiful line. It's a beautiful, beautiful line, a beautiful scar that you've chosen. So I personally don't think it's worth that larger procedure, which is and has a risk of a flap failure because of the flap going down and then just getting an even bigger wound for that reason. What are the other downsides of flaps? Well, I've seen disease occur for that same reason that the disease is in the skin that does not look affected. You can get disease that occurs along the flap, and then you end up also losing the flap, and it's a bigger space and a bigger issue. And oftentimes the tissue will fall apart because we know that there's inflammation in the tissue, and tissue doesn't heal well where there's inflammation and or there's a higher risk of infection. So that's why I and Dr. Dave Louie and some other leaders in the HS world have really moved towards the secondary intention healing, but it is really something to discuss with your doctor. You're welcome, and happy to answer any other questions.
Let's move into the...
All right. So, oh, this is bright. This is a sweet rope.
Oh, hold on. I guess we could, I don't know if we can move this. It's taped down.
No, I mean.
Oh, yeah. Okay.
Yeah.
Got it. All right.
Oh, okay. Oh, are you videoing? Hi. Okay. This is a sweet rope, Candy. It's my favorite tool that I use to teach the medical or the dermatologic residents how to de-roof things. And we have more that we can hand out if you want to try it, and we could go to the back of the room to do it. I have scissors and I have forceps. This represents a tunnel. Inside the tunnel, you have the jelly. The jelly is white, okay? The tunnel itself is a good thing, actually, okay? It's the jelly that's not a good thing. So what do we need to do? We need to open up the tunnel. We can leave the wall of the tunnel behind, and we need to scrape out the jelly. It really, and what I want to show you guys is that this is something that you can do. Again, don't do this at home, okay? But I want you to understand literally the motions that we go through to do this, and how in the grand scheme of surgeries, when we talk about surgery, I don't want it to be as scary to you. So we have a tunnel. I don't know if you want to come up on here. Can I put the microphone down? Actually, Christine, come hold the microphone. And let me just, Brinley, there's lots of scissors as well opened in the bottom of the box, other box that's going around. Okay, so what we're gonna do, this is a tunnel, and pretend like there's skin on top of the tunnel that's intact. Sometimes it might be draining, sometimes it might not be draining. But I'm gonna make a hole in it, in the tunnel, and I'm literally gonna just cut down the tunnels. And when I'm doing this, I'm cutting the skin. And I'm gonna take, since it's called a de-roofing, I'm gonna take the roof off the tunnel. So the reason we call it a de-roofing is think of a house and, oh.
So it's like you want to cut the red part without getting too much of the white. So like shallow cut along the red to make a little like square.
And I'll walk you all through it too in the back. I'll come to the back of the table in a second. Oops. So the reason it's called a de-roofing is because think of looking down at the roof of a house, okay? And we're gonna literally take off the roof of the house, and then we're gonna remove everything down to just the walls and the outside border. That's all a de-roofing is. So we're cutting the top, and I don't know if you can see my fingers here, off of the roof. You can eat it, but with everybody's hands touching it, I'm not sure I would recommend it. Plus, there are many people in this room who will tell you it's inflammatory. I was going to say, I did have 2 yesterday. Okay, so now what you have is we have a tunnel where we've taken the roof off, okay? Just literally cut the top off the roof. The back is still there. And you have all the jelly, which here looks white, and we have to remove the jelly. There's lots, what's that?
The red is your skin, and the white is the inflammatory jelly you're gonna scrape out. So you essentially cut the roof off of the red, and then next step is scrape out that inflammatory white jelly.
And you can also access it from this side.
Right. Try not to cut through the green though. No bueno.
So now what we're gonna do is we're gonna remove the jelly. And there's a number of different ways we can remove the jelly. It's not a one size fits all. Everybody has different technique. I'm gonna show you right now by just scraping it off. And that's basically what curettage is.
So she's using the back of the tweezers, which is like a little paddle, and use that to scrape out the white for everyone in the audience who's not watching virtually.
As a curette, and what we see is the green, which is the bottom, and then we put some Vaseline on top, and we say, go home. And we say, you don't need to do anything else. Well, you need to shower every day and put more Vaseline on, and it's going to heal up beautifully. That's it. That is a de-roofing.
Amazing. Thank you, Dr. Goldberg.
I will be happy to walk anyone through this in the back or during lunch. Okay. Thank you. Yes. So the question is, do we have to be a certain severity or stage? So if we go back to the different type of things that we see underneath the skin, if you have don't think about it in terms of stage. Think about it in terms of what's below the skin. If you have a solid nodule, there's nothing to de-roof. If you have a scar with no disease in it, or no active disease, there's nothing to de-roof. If you have a tunnel, there's something to de-roof. And what I find, and this is one of the things that brings me joy as a surgeon in this space, is I have people who might have big areas like this big that are all inflamed. And it's a combination of scar and tunnels. And that's when we go through and we find all of the different tunnels. Sometimes there's scar in between the tunnels. And we open them up and we scrape them out. And the nice thing, especially on the buttock area, is that we're not taking a chunk of your butt out because we're not going down to the subcutaneous tissue. So it's much more comfortable to sit. You don't have that cosmetic deformity either. So it's not necessarily, now, if we talk about the stages, tunnels don't enter the picture. Oh, you know your stuff. Tunnels don't enter the picture until stage 2. But it doesn't mean that there's not techniques that we can't use for stage 1. In general, stage 2 and stage 3 is more amenable to surgical interventions. But the Hurley stages, really the purpose of the Hurley stages, as far as I'm concerned, is if another physician tells me, I have a patient who has Hurley stage 2, I know in my head what it looks like. Other than that, I really don't find great value in it. So. All right, thank you all very much. This was fun.
All right, all my little surgeons out here, your de-roofings look wonderful. Lunch is served, so we are going to do lunch, and then we will do laugh yoga, which is the activity after lunch. It's a burger bar. There are plant-based and gluten-free options available. So enjoy your lunch, and we will corral you for laugh yoga afterwards. Thank you, everybody.
See you at 12:45. Oh, see you at 12:45. Everyone, hope lunch was good. We are going to get going with our next speaker. We've been talking a lot about genetics and HS today, and we have with us Dr. Lynn Petrikova to go over that a little bit more. She is one of the leading researchers on HS and genetics, specifically at NYU, and we are very excited to hear from her today to present all the exciting information on this in plain-ish English. So give it up for Dr. Petrikova.
Okay, thank you. Can you hear me okay? I tend to speak really loud and get very excited when I talk about genetics. So if I'm too loud, just tell me to keep it down. First thing you need to know about me, most important thing, I have no clinical training. So if anything I say today sounds like medical advice, raise your hand so I can explain why it's not medical advice. Second thing to know about me, I've been in love with genetics since I was in middle school, 7th grade. I remember the first time I learned about it. But I did not realize that I could make a living from it until I was in my 30s. So I went back to school in biostatistics, and then I could not get a job in a statistics lab, so I ended up in a dermatology lab, being the only statistician. I was a little bit disappointed at the time, but it turned out to be the best thing for me, because I was in a lab where when I started talking about numbers and statistics, I got blank looks and questions about what does it mean. And that really pushed me to realize that statistics is just a starting point. And so the goal of my research is to use the statistics as a tool to get to the genes, the pathways, the cells, the tissues, and the treatments. So what I'm gonna do today is to start by, where's my clicker, or next slide? Yeah, this is my agenda for today. I think the human genome is the coolest thing ever. So I'm going to talk to you a little bit about why I think it's so cool. And then I'll explain to you how we use it for our human genetic research. And then I'll give you a framework for the causes that I'm looking for with my genetic research. And then in the last section, I'll give you 2 examples of new biology that we're learning from our genetic studies. Next slide. Yep, next one. Oh, all the animation doesn't work. So to jump ahead, yeah, so everybody knows that the human genome is like a set of instructions, right? The building blocks for life, the encyclopedia of how to build a human, it's all in your genome. Your genome also has a ton of information that your body is using today. So you get exposed to the flu, how's your body gonna combat that? Instructions for that in your genome. How to keep you healthy, how to respond to tissue damage, all of that information is in your genome. Not only that, but the genome has been collecting information for tens of thousands of years. All the information that your ancestors collected, like when they survived the plague, that left an imprint in the genome gets passed on to the next generation, preserving that. The thing that I love most about the genome is it's a tool that connects people. And so your genome is actually much, much older than you, right? Tens of thousands of years ago, which means that if you take any 2 people in this room, even if you've never seen them before, you're sharing DNA. At some point in the history, and it may be 1,000 years ago or 5,000 years ago, you had a common ancestor. And that common ancestor passed down DNA to both of you, which means that you share part of your genome with every person that you meet. Next slide. So if you take a group of random people and look at those places in the genome where it can vary, that pattern should be completely random. However, next slide, if you take a group of people who share a diagnosis and start comparing their genomes, you'll start to see patterns emerging. Yeah, the animation isn't working. So here, you see this pattern, right, with the red fishes. And then you sequence a 6th person, and all of a sudden, it's not a red fish anymore. What does that mean? Was it just by chance that there were 6 fishes in a row, or is there a pattern there? The only way to dig down deep into that is to sequence thousands and thousands of people. Next slide.
Can I ask a quick question?
Sure. Oh, that's a great question. Genome is the whole unit of DNA that's in your body. The genome contains about 18,000 genes in it. and those genes have very specific instructions for the way it's going to make proteins that make up your body.
Perfect, thank you.
And then, so your genome has 3 billion base pairs in it. Those are the letters or the sequences that they talk about. 99.9% of them are the same between everyone. And then 0.1%, or about 6 million, I guess that would be 0.2%, 6 million of those base pairs can be different between people. And those are the ones that we dig through to try to find the patterns. Next one. So the most important thing about conducting a genetic study is the size, right? The bigger the size of the study, the more information you're going to get. So on the far side, that's like conducting a study with 1,000 people. You see some different colors. You can't make out any patterns in that or figure out what you're looking at. You get up to 4,000 people, and now you can see, well, maybe there's a man in the corner. But it's not until you start getting tens of thousands of people that you can make out enough detail to try to figure out what's going on. Next slide. So this is an example. These are some skin diseases that I and others have been studying with genetic studies. You can see the number of GWAS, or genetic studies, that have been conducted for each of those diseases. The number of cases that they've included in that, so you can see how much that varies. But the most important thing is how much the number of, so a loci is a region in the genome that's different between the cases and controls. So like, look, for example, alopecia areata was the first GWAS I ever conducted. And there have only ever been 2 alopecia areata GWAS. And so we only know 14 genes about it. On the other hand, androgenetic alopecia, that's patterned hair loss, so male pattern hair loss. Everybody care, like all men care about losing their hair, right? So look how many people they got in their study. 200,000 men donated data. But look at the yield, 624 loci. This is going to become important halfway through my talk. Tons and tons of information there. So even the HS, when I wrote this paper like 7 months ago, there were only 2 GWAS, and now we're up to 5, I think. 12 loci, the largest one. We're going to talk about that later. Okay, so the biggest message is like we need lots and lots of people participating in these studies. Next slide. Okay, what are we looking for? Next slide. Oh, all my animation. So I start every talk that I give to other scientists and medical people by saying that HS is one diagnosis, but it is many diseases. This is a message that I don't need to repeat to you guys here. So we know that like a lot of examples have come up over the last 2 days. Like some people get their first lesion when they hit puberty. Other people have no problems until they hit their 40s. Some people change their diet and their disease goes into remission. Other people lose a ton of weight and their skin gets really angry and flares up, right? So there's lots of evidence that we're dealing with multiple diseases. And this is important because if the disease is different, the biology is different, and the treatment should be different. So today they come up with treatment algorithms for HS. You come in and based on population data, on average, we should start with this treatment first and then move to this one and then move to this one. The goal of my research is to be able to assess a patient when they first show up to find out like what is the flavor of HS that they have. That gives us information that like adalimumab will not work on this person. Don't waste your time with it. Next slide. Right? And so there's really 2 different causes that I think, or 2 types of causes that I think about when I'm conducting my genetic studies. Causes that are shared or common, those painful lumps and boils, like what's creating them. But almost more importantly, what are the causes that distinguish these different types of HS? Next slide. Oh, all the animation is gone. So my favorite thing to think about when I try to figure out like what are the different types, comorbidities. I think that's the single most important clue in figuring out these subtypes. We know there are tons of studies showing for sure that there are lots of different comorbidities, But my idea several years ago was that nobody was looking within individual patients, right? So like type 2 diabetes is definitely a comorbidity. So is inflammatory bowel disease, but nobody was looking within individual people. If you have IBD, are you also at risk for type 2 diabetes? Or are they separate mechanisms or diseases? So my idea was if I could collect a lot of information about comorbidities, I could use fancy computer algorithms to sort through it and find patterns. We ran a preliminary study a few years ago using comorbidity data, and it showed us somewhere between 3 and 5 different types of HS we'd find. It was small. We're trying to repeat that. The other thing that I learned, you can go to the next 2 slides. The other thing that I learned is that medical records are terrible ways to get information about people's health. They're created for billing, not for research. And so I designed this Skin Deep survey to go out to the community to find out from the people who are living this experience, what are all the health conditions that you experience aside from HS? It's a long survey, so it can take, depending on how many other health conditions you have, it can take up to 25, 30 minutes to get through the whole thing. But the idea is we collect this data. You're also given the opportunity to participate in our genetic studies. You can complete the survey without participating in the genetic studies, but if you want to participate, you give us your contact information at the end of the survey. We send you a saliva collection kit with materials to ship that back to us, and then we enroll you in our genetic studies, sequence your DNA, throw just that de-identified data in that pool with the thousands of other DNA sequences that we have to start finding those patterns. Next slide. So I mentioned, like, here's an example of some of the comorbidities that are emerging from our genetic studies. And this kind of information goes both ways. So in that first example, we discovered a new gene in our studies. And it is a gene that has been published in other painful conditions. And so based on that knowledge, I went into the medical records of the people in the study, and 2/3 of them had a diagnosis code for migraines. So like, it's a preliminary study. We're doing a lot more work to that, but that's an example of how like the gene led us to a comorbidity. Second one, an example of like comorbidities leading us to think about a certain set of genes. And then the third one is an example that I'm going to give you today. How many people have heard that you're at an increased risk for cavities if you have HS?
I noticed that my gums swell, like when I'm having flaring, like gums, like my mouth hurts.
Uh-huh.
I noticed that for years, and I just all associated it together.
Yeah, so it's definitely HS. So we had another genetic discovery, and when I started reading about these genes and the types of diseases that they caused, cavities came up in it, and I went into the literature, and very recently there's a pretty well done study from Italy showing an increased risk of cavities. It's difficult to interpret those epidemiological studies because we also know that people who have HS are consumed managing their HS, right? So they're less likely to have a primary care doctor. They're less likely, especially in this country where a lot of health insurance does not cover dental care. So like all of those things are going to contribute to it. But we're finding evidence that there may be a genetic link between like dental outcomes and HS. For some patients, that's an important part of it. Okay, so I'm going to walk you through. Does anybody have any questions about anything that I went through right now? Yes?
If I gave my saliva and blood to my local... Is it working? Hello? There we go. If I give my saliva and blood to like my local clinic, like health system, did it make it over to you?
That is a great question. The answer is maybe.
Okay.
One of the things that I've been like working really hard to do, so you heard earlier there are a couple different groups studying genetics, and we are working hard to form this consortium so that we're all working together and synchronizing our DNA. And so I would say that it is possible, and depending, I mean, I can tell you to like, I know the people who are active in their genetic studies, and so I will know. But then the other thing is, it doesn't hurt to participate twice to a genetic study. There are computer algorithms now that can figure out if you have this duplicate samples in different cohorts or different samples of people, and they can make statistical adjustments to it. So, yeah. Any other questions right now? Okay, so we're going to move on to the funnest part of the talk, the discoveries. Next slide. Okay. Yes, so this story starts last spring. Another group led by Professor Yemek published their GWAS, and they found a variant, a very specific locus in the genome that falls within a gene called Wnt10A that was associated with HS. Next slide. Yeah, so what does that mean? Very particular location in the genome, comes in two versions, a pink version, the red, purple version, T. And so you can either have like an A or a T. The A is pretty rare in the population, so 2 or 3 people out of 100 will have it. However, when they counted that allele in their group of people with HS, they only found 1 person with it, right? 2 instead of 1. Next slide. So that's what we call a protective allele. You're less likely to find it if you have the disease. The way that we interpret it is that there was somebody in the population who was supposed to get HS, who had all the other risk factors for HS, but didn't get it, and they didn't get it because they had that A protecting them. So the big question is then, how is that A protecting somebody from getting HS? Next slide. So that group is led by, so Dr. Gregor Yemek, maybe some of you will know him. He's like the godfather of HS. If you think of something interesting about HS, he has published at least 1 paper on it. Everybody knows him, brilliant man. But he doesn't do genetics. And I was writing a review paper at the time that was published, and I recognized that variant, or that SNP. And so I went back to my research, and I saw somebody had reported that in acne also. And then, even more interestingly, it was reported as a cause of a pediatric disease called short anagen syndrome, and I'm going to explain it more in a second. And it was also shown to increase risk of male pattern hair loss. And to me, I was like, this is so exciting. Why didn't he include that in the paper? Because HS is a disease of the hair follicle, and now we have a variant in a gene that we know is doing something in the hair follicle. So our group published this little letter just reporting that. Next slide. So what do we know about those 2 diseases? Interestingly, short anagen syndrome is sometimes considered the pediatric form of male pattern hair loss. Who knew that there was a pediatric form of that disease? Pretty cool, right? So before I explain what we know about these diseases, I'm going to start with our little diagram at the bottom showing the hair follicle. So hair follicles cycle, which means that they spend some amount of time growing, producing your hair fiber. And then at some point, it shuts down shop, packs itself up, and goes into this state of quiescence or rest when it's really short, just sitting there. And then at some other point, something triggers that hair follicle to wake up and start generating a hair fiber again. Cells start proliferating, they migrate down, they start generating the fiber that grows up. But what happens with male pattern hair loss is that when it enters that second growth cycle, it's not able to get as big as it was the first time. It shrinks in size. And so you can see that in the clinical photo up top. They've labeled terminal hair means that it's dark and pigmented. That miniaturized shows that the hair follicle has been shrinking down. They call it miniaturization because some forms of hair loss, like the hair follicle is completely destroyed and it just can't do anything. But in this case, the hair follicle is still cycling, it's just making a smaller hair follicle. Now, with the pediatric form, it's like the opposite happens, right? Infants are born with peach fuzz, and at some point it starts growing and it generates a longer hair. With short anagen hair syndrome, something doesn't kick in and it doesn't produce that terminal hair follicle. So what happens is usually around the age of 3, the parents realize that like, okay, I've never had to cut this child's hair, something's wrong, they'll bring them to the doctor. And so that the little girl on the bottom has never had a haircut, her hair just didn't grow. And up top, even the pattern is similar to some forms of male pattern hair loss, right? But what happens is there's no treatment for it, but treatment isn't really needed because when the kids hit puberty, the hair starts growing. The disease just goes away. And that's also super interesting to me because that's the opposite of what's happening with the male pattern hair loss, right? So that's like sex hormones are somehow influencing both of these diseases. So, you know, this discovery generates a lot of really interesting questions, but it gives us a direction, like questions that we should pursue with experiments. Is it the androgens, right? Is it just having a smaller hair follicle or a shorter hair follicle or a hair follicle that doesn't have pigments, right? There's still explanations, but there are fewer than we had before this genetic study. Any questions? Okay, next slide. So those are the diseases I recognized off the top of my head, but we went into this like large public database and asked what other diseases have been associated with this particular variant. That's the statistics. We can go to the next slide for the English. Okay, so here's how you interpret it. If you have an A, you're at a greater risk of short anagen syndrome, male pattern hair loss. There's been one study showing that those people with an A are more likely to get a diagnosis for cancer. It's a sloppy study because they don't specify the kind of cancer, and that's a really, really important thing in cancer. But it's there. And then tooth agenesis. So children are supposed to grow 20 teeth at some point in their childhood. Agenesis means that they're missing one or more teeth. It just never comes in. So that happens if you have the A. And if you don't have the A, you're at an increased risk of HS, acne. This one I love. You're at a risk of youthful appearance. But I love it for another reason. People are always distressed about their genes and what are the bad things that my genes are doing. And one of the most important discoveries from all the genetics is that there aren't good genes and bad genes. There are genes that do things. And this gene that increases your risk for HS keeps your skin looking young and pretty. You're also, here, Christina, that's for you. You're also at an increased risk for cavities, probability of wearing dentures or wearing dentures because your teeth are falling out. Okay, so the take-home message from this slide is not if you have HS, you're going to get cavities. The take-home message is that I think we have a subtype here. I think that if we find patients who have a lot of dental problems and they have HS, they may have a problem with their Wnt signaling, right? Wnt10A is part of a larger group of genes that does this thing called Wnt signaling. What we still have to figure out is what that means. How does Wnt signaling fit in with like TNF signaling, right? There could be an overlap there. Just because it's Wnt doesn't mean that adalimumab won't work, but we have our work cut out for us now to figure out what those relationships are. But it's also important, yeah, no, you can go forward, because it tells us that there are subtypes, right? So it starts to give us a way to start to classify people. Okay, so that was the study I just told you about. All of that work was just from one variant. The next question that I asked myself is, could there be more variants in the genome contributing to that relationship between hair loss and HS? And so to do that, we used this technique where we take all 6 million genotypes, 6 million variants that could be different, and we compare them between a male pattern hair loss GWAS and an HS GWAS. And we asked, do we see like more in common than we would expect, and than by chance? And we did see more in common than we expected by chance, and it was in the opposite direction. So that among those 6 million, there's like 2 million that if you have one allele for HS, the other allele's gonna be causal or increased risk for male pattern hair loss. Next slide. All of my beautiful animation. So why is this important? Why was I so excited about Wnt10A? I'm gonna digress to a story about Conrad Reed. Does anybody know about Conrad Reed? Somebody here is from North Carolina though, right? Yeah, so you should know about Conrad Reed. Conrad Reed was the first person to discover gold in this country. And the story, it's a great story. He's 12 years old, living in North Carolina. Sunday morning, his parents go off to church and he talks them into letting him stay home because he's worked hard on the farm all week. They agree. He goes down to fish in the stream with bow and arrow hunting. He goes down to retrieve his bow, and he finds this big shiny rock. And it's so beautiful. He brings it home. The family uses it as a doorstop for 3 years. They decide to bring it into town to see if they can get money for it because it's so pretty. And the person at the stone store says, "That's gold." That's not just a pretty stone, that's gold. It was a piece of gold worth $3,500. So this is back in 1799. That was a major red flag. Maybe there's more gold. So then they start panning, and indeed there's more gold. There's enough gold there that they decide to build a mine. And over the next 50 years, they mined millions and millions of dollars worth of gold from this one mine. And then eventually the gold rush moved out to San Francisco, and the mines in North Carolina sat down. But I like that's how we should be thinking about this Wint 10A discovery. Wint 10A is a big chunk of gold. That second study, we're panning, there's more. We need to start building a mine and digging deeper into it. Okay, next slide. Just a quick summary of that first story. There may be a unique clinical profile associated with dysregulated Wnt signaling. What's going on with these shrinking hair follicles? Is it the hair follicle itself? Is it hormones? The reason why I love it is because it starts to give scientific evidence to support the use of treatments that destroy the hair follicle or target the hair follicle, like laser hair therapy. So we're taking this to the patient advocacy groups to think about how do we incorporate this into our arguments when we go speak to government officials. Yeah, the other thing that it points out is, I don't know if you were at the HS meeting before this, lots of clinical trials for HS, which is a really exciting time, but all of them are thinking about how do we manipulate the immune system to quiet down HS. What all the genetics, my genetic studies, Chris Syed's genetic studies, Gregor Yemek's genetic studies, they're all converging on the hair follicle. So we need to start thinking both about how those immune modulators are affecting the hair follicle and to start thinking about, are there ways that we can manipulate the hair follicle that will leave your immune system intact and still quiet down the HS? And we need a lot more studies about hair follicles in HS. Okay, next slide. So next example, causes that are shared. Next slide. Yeah, next slide. Next slide. So this is a great example of bigger nets, more fish, and you'll see that in the next slide. So the very first HSGWAS I conducted was back in 2018. 600 participants, no regions. So when you're looking in the genome at 6 million variants, by chance you're always going to get some sort of pattern emerging. So statisticians have figured out where that red line is. You need to cross that red line to be sure that it's not a chance association. The way you can think about it is if you have a bag of chocolate chip cookies and most of the cookies has 7 or 8 chocolate chips, you could reach in and pull one out that only has 3. That's just by chance fluctuations. So anything below that line is just luck. So we're looking for associations above the line, dots above the line. When we moved up to 4,300 participants, so what happened was we took our failed experiment and we started sharing it with the community, going to meetings and saying, 500 isn't enough. What we could do, we looked at the results we had and we could estimate we'd need 2,000 to 4,000 people to start getting results. Lots of groups had about 1,000 cases. Nobody had 4,000, but if we pooled them together. So the difference between the first one, I'm working alone, 4,300, I've now got 5 other groups working with me, combining their data. We've got 3 loci, 3 regions. And then a few years later, we've got about 20 groups donating data, 6,300 participants. We go from 3 to 12 loci. Okay, next slide. Yeah, so that's exciting, but it's still, we're only about here. Next slide. But I'm going to tell you the story that emerged from us, from our data for us. At that peak on chromosome 2, so you're looking across the genome, you've got 22 regular chromosomes and then some sex chromosomes. Here in this plot, we're lining them up end to end. On chromosome 2, where that second peak is, there's a gene called CXCR4. And it turns out that CXCR4 acts as a GPS, a global positioning system for cells. When cells need to go somewhere, they turn on this gene, and that helps them figure out where they should be going. Next slide. So it turns out that there's a lot of cell movement and migration in just normal, healthy skin. So this is in development, right? And so we're looking at like fetal skin. When your skin first forms, it's just a single layer of cells. And then what happens is in bunches, you'll get these bursts of proliferation. The cells will start dividing, and then they also start migrating down. So you can see in that third picture, those migrating cells are pushing the red cells down into the skin, and then at some point they stop tunneling down, and then they start working together to generate the hair fiber. Now this happens only once in development. Next slide. But because the hair follicle cycles, it happens over and over again as adults. But it's that same concept. So in that box, I'm showing you like when the growth period starts, you get that same burst of proliferation. Those pink cells start multiplying and start tunneling, start digging down. So those are two situations where migration is important in the skin. Next slide. And then there's a third situation where migration of skin cells is really important, and that's when you get a wound. Did anybody know that like when you get a cut on your skin, do you know where the repair cells come from? I didn't even know this until very recently. Actually, nobody in the world knew it until about 10 years ago. It's the hair follicle. The hair follicle donates cells. It like wakes up and it starts proliferating, and it sends the cells up and out across to find that wound and to fill it in with new cells. So lots of migrating, right? So really cool that we found this GPS, this gene that helps them go. And especially because in HS, we know that there's a lot of cell proliferation and migration that shouldn't be going on, right? Epithelial cells are pink in that picture on the left. We should have a thin line of them at the top of our skin, and they should surround the hair follicle. And then in HS, it's pink, it's purple in this picture, not pink, but you can see how much thicker it is in HS skin, and you also see those dermal tunnels, right? Those tunnels have skin cells that should be at the top of your surface, and now they're way down in the dermis. So lots of aberrant proliferation and migration going on with HS. We're super excited that we found this GPS. Next slide. So the first question we asked is, if it's involved in migration, do we see it in places where the cells shouldn't be? And indeed we did. So now we're staining the protein in brown, and you can see that that top, do I have a pointer? So along the whole surface, there's like epithelial cells, they're called, those skin cells, but only some of them are expressing CXCR4, and they're the ones that are misplaced down in the dermis. Next slide. So then we did a bunch more studies to like look at the molecular profiles of these cells specifically, and it turns out that there are a bunch of genes on, not just CXCR4, but a bunch of genes that we know come on when cells are migrating, bunch of genes that come on when there's too much inflammation in a cell. They were all on and screaming. You can think about like the volume being turned up to max for these things in these cells, and then lots of genes and proteins that come on when cells are proliferating. Okay, next slide. So the other thing about CXCR4 is that lots of people have been studying it for lots of different reasons, and there are molecules or chemicals that will bind very specifically to CXCR4 and shut it down as a GPS unit, right? It like turns off the battery, can't work anymore. When we did that, all of a sudden those migration genes got turned down, the inflammation genes got turned down, proliferation genes got turned down, and then we saw a bunch of genes coming on that come on when cells die or shrivel up, stop doing things, and a bunch of genes that come on when like the hair follicle is restoring itself or entering into the growth phase after the proliferation phase. So next slide. So what that told us is that, you know, we're at the opening of a mine here, and there's a lot more digging to do. All of this is very preliminary. We're looking at one experiment in one cell type and seeing encouraging results, but there's still this huge gap between like what's going on with this cell and how can we leverage this to bring new treatments to HS. Next slide. So lots more experiments need to get done. I'm trying to hire wet lab people who can like, there's so many cool experiments we can do with the hair follicle. So with a skin biopsy, you can actually cut out the hair follicles and they'll grow in culture. So what I'm really excited to do is like get some hair follicles in culture, and now we can start playing with like adding drugs and adding chemistry and ask what happens to the growth when we start adding these drugs. Does it speed up or slow down? Does it die sooner or later? We're also trying to create a mouse model. That's a prerequisite in drug development. Before you go into humans, you have to have evidence in mice, and right now there isn't a good mouse model, so our group is also working on that. And then most importantly, we need larger GWAS. Next slide. Yeah, so we're here, but we need to be over here. We get more information. We can know more about what's going on in that cell. We can try to figure out like why CXCR4 is coming on, like upstream from that, if we have more details, more information. We also know there's lots of different cell types in the skin. And so we know it's not going to be just this one cell, but how is it interacting with fibroblasts or immune cells? So we need the more resolution, bigger studies. And I think I might be at the end. Next slide. Yeah. So that's the QRC code. I had it before. There's also a website. If you have any questions about genetics in general or this study, call or email me, or Jaylene is really great. She's my new research coordinator. That's her email and cell phone. And with that, next slide, I will thank all of my collaborators. These are big endeavors. I am by no means working alone. Lots of funding agencies and our genetics partners. Thank you.
Thank you, Lynn, so much. I have a quick question. So anybody in this room can sign up for that study, correct?
Yes.
Can we put the QR code back up there so that everybody can join right now? No pressure, but pressure.
You can go to the study and not complete it. You know, just like look at it. It's not a commitment if you follow the QRC code there.
Yeah. But this is how we get from the middle picture to the end picture. So, any other questions?
No, there's a question.
I'll start over here with Cassandra.
Hi. So I'm over here.
Yeah.
Hello. It's not so much a question as much as a statement, but I really appreciated seeing the different comorbidities, like especially because I had no idea that the dental stuff was there, and also with youthful appearance, because there's I never got to, my biological parents are no longer alive, and I always suspected that, well, not always, but as soon as I learned that I had HS, I suspected that my biological mother had HS, because she always complained about a cyst that was on her chest that would like ooze and stuff like that. But she also, like, hearing that, it makes so many things make more sense, because she had severe dental issues as well.
Oh, interesting.
Yeah, and she looked very young, and she was like in her 50s when she died, but she looked very young. And so and she had acne too. So like it was checking off all of the things on the list. So I think I was getting like personally more confused when it talked about the new gene, but like particularly in seeing the different comorbidities and how much HS connects to other things was really interesting, and kind of reaffirmed that there was a connection and like a reason why I developed this condition.
Yeah, thank you for that. And I'm sorry about your parents.
That's okay.
And I think, but it also points out why these studies are so important, why your information about your experiences is so important. Because there are going to be other patterns like that for HS, right? That's like one profile, one pattern. There's going to be more, and the only way that we can get to that is by looking at bigger sets of data.
Anybody else? Erin? Yeah. You're not getting away from the mic, Erin.
Okay, so I don't know if this makes any sense. It's not a full thought, but just thinking about male pattern baldness, and one of the treatments with that is like when they like stab all the hair follicles out where they find healthy on the body, and then put it on the scalp in areas so like they kind of like transfer it. Is that something that we could look into as like a treatment option for us if we were to just remove the hair follicle instead of like cutting out all of our skin, if it's like more early on?
Yeah, no, that's a great question. And I'm glad you brought it up, because there are some of the HS treatments we know affect the hair follicle. Laser hair treatment, right? So many people, not everyone of course, but so many people report that after the laser hair removal, their symptoms get better, right? And so this is saying there's a biological mechanism there. Spironolactone is another one that affects hair growth, and it helps for some people, it helps with HS. Finasteride, another one. We know it's doing something to the hair follicle. It's also helping with HS. But those are all things like this spironolactone and the finasteride, like those are like accidental discoveries that they'll help HS. People don't understand the mechanism. So what our research also shows is we need to get into the lab and figure out like, what are those drugs doing to the hair follicle? How are they helping? Yeah.
Thank you.
Anybody else have any other questions? I feel like there was a lot more hands up at first, and now nobody wants to.
So I know you were mentioning that we're pretty much all connected at somewhere down the line. As far as genetics goes with HS, so this is new to me. I've been dealing with HS for a long time, but I was dealing with it by myself. Earlier this year, my little sister was diagnosed with HS, but we don't have the same mother. Is it possible, I know, so I automatically assume that it's on my dad's side somewhere, but with us having different parents, I'm thinking it could still be possible that it may just be on both sides of our, on my mother's side and, on her mother's side. So is that something that can be traced or
so yeah, that's a great question, and there's a couple of different answers to that. There are rare familial forms of HS, is the term that geneticists use, where like you will see large families where it co-segregates. So many relatives have it that it suggests that there is a gene in there, and in fact, in some of those families, we have found a very specific gene that carries a variant consistently with HS, telling us that it happens. Those are so rare that like 2% of HS people from all of the studies, maybe 2% have a mutation that works like that. If you do have that, that particular gene, you only need to get one copy of it, so it is possible that it came from just one parent and get passed down. Most people, the genetics that we do with the GWAS, each one of those variants have such a tiny, tiny effect that hundreds of them are needed to like push you over this threshold to get HS. And in those cases, you're getting it from everywhere, and they're like, each one individually is really small. One way you can think about it is like, there's lots of different ways to get to $2. You can have two $1 bills, 8 quarters, 200 pennies. At the end of the day, it's all $2. So there's a lot of different ways that genetics can influence it. But the most important thing of all is one of the reasons why I was really interested as an epidemiologist to look at HS is because there are environmental causes of it. So there are some drugs or toxins that if you give to anyone, regardless of the genes that they have, it will trigger symptoms that look like HS. And so it's possible, and some of these, like, well, there's a very famous one. There's a poison that the Russians like to use, and they tried poisoning somebody, and he got this like pseudo form of HS, and it's in the medical journals because people used it as an opportunity to understand what was how this toxin was affecting the skin and causing boils. Anyway, so it's not all genetics is the most important thing.
So is what you're referencing there like gene expression, right? Versus like when you inherit whether your gene is expressing a certain way and how that can be manipulated, I guess, with medication and or lifestyle environmental factors.
Exactly,
Okay.
Exactly. Thank you.
Okay, guys, is that it for Dr. Petrova? That was super insightful. Thank you. Do you want to talk about the double hair thing really quick? Because that was really cool.
Oh, yeah. So there's this I love this story so much because it just captures so many things about like how great a community you guys are. So there's a listserv where like dermatologists from all over the country post questions about things. And one day a dermatologist said, my patient noticed she's got 2 hair fibers coming from most of her hair follicles, most of the pores on her arms and legs. Does anybody know if this is related to HS? And it was largely crickets, and a few people said, no, not likely, we've never heard of that. Because I was studying hair as a student, I like reached out to the hair people and said, is this a thing? What's going on? And they were like, yeah, that definitely shouldn't happen. On your men's beards and scalps, it's common to have 2 fibers, but not on your arms and legs. And so, like, as a hair biologist, I'm like, I need to know more about this. So in that survey, I added a question, do you have 2 or more fibers coming out of your pores? And I asked my research coordinator to like do an analysis when we got our first 100 people, and she's like, oh, 45% of the respondents said they have it. And I was like, no, that's wrong. Go redo it. And then I looked at the numbers and I'm like, okay, I'm not asking the question right. And so I went to ask Brinley and Christina, I'm like, is there a better way that I could ask this? And they were like, no. So anyway, so I have no idea what this is and why like so many people with HS are saying that they've seen that or they have it. But I am really excited to get the genetics to start trying to understand if there's like some sort of gene that's increasing the probability of that happening.
Crazy. I have the 2 the hairs, yeah.
Oh my God!
Right? Okay, super cool, right? To make the point. Thank you so much. All right, everyone, we are going to roll in. Okay, guys. Okay. So we're going to roll in to mental health with Dr. Karabar very, very shortly, but I do want to give anyone a chance to go drink some water, go to the bathroom really quick, but no lollygagging, y'all. Don't make me go get you. Make it fast, because we got to keep it rolling. We're going to go to Dr. Bars, and then we'll be... Oh, 5 minutes, 5 minutes. 5 minutes, and we'll go into mental health. After that, we have a 30-minute break, and we will finish off the day with sex therapy giveaways. So don't take too long. Yeah. for their HS, and it sucks. So Dr. Kirbar is a dermatologist by trade, but she now focuses on this like mind-body connection, and we did this incredible somatic, like skin. What was this? Like, it was like how many sessions was it? It was a lot. It was 8 sessions over the course, every weekend. So it was 8 weeks, and we met weekly, and we really walked through all the different ways in which, the way that we think and the way that we breathe and the way, so many different ways to manage our HS that don't have to do with what you put in your body and on your body. And it's such an important piece of the puzzle. So welcome, Dr. Barr.
Thank you. Thank you, thank you. Yeah, so we just had an amazing talk on genetics, and my intention is to try and connect all the dots of why genes get turned on and why genes get turned off, because everything is connected. And I was telling Christina, I actually gave a talk to dentists and oral pathologists all about the role that chronic and traumatic stress plays in creating cavities, tooth loss. So it's not this random, all these comorbidities aren't random. They all make sense once we understand how everything is so interconnected. So on that note, I'll go to the next slide. So I am going to be sharing some education, but also we're going to be doing some practices together. We're going to actually start off with one. And so this is a reminder to take good care of yourself during our time together. Everything that I offer is an invitation, not a directive. So I trust you will opt out and opt in as much or as little feels right for you. And that's the most important part, yeah? Next slide, please. So I always love to, we'll move on to the next slide. We're just gonna arrive together. Oh, sorry. I'm talking to myself because I'm trying to keep myself on time. Okay, so we're gonna arrive together. Because we were just on break and had a lot of information in our head, I love to kind of bring us into our collective space so that we can move forward together. And this past weekend, I was at an event where I learned a new practice. I wasn't planning on doing this, but I think it's really a valuable one, because I don't know about you, but I'm feeling a little buzzy right now. I've got a lot of stuck energy. We've been sitting for a long time, and this is a really wonderful practice to move that stuck energy through. It's kind of like having an espresso without having to take in the caffeine, or it's a wonderful practice that you can use when you're feeling a little pent-up frustration, you're flaring, you're uncomfortable, and you just want to get it out. So this practice is called the Ha breath, and it has 2 parts. And why this practice is really helpful is because in order to change our state, the way we think, the way we feel, the way we just kind of show up in the world, we need 3 things: breath, sound, and movement. Right? This is really the language of the body. So breath, sound, and movement, and the Ha breath gives us all 3. So it's a 2-part breath. Hopefully you'll be able to hear me when I step over here. But to explain, the first part is we inhale through our nose. I'm gonna yell. Is that it? Or shout or speak loud? Is that okay? Yes. Okay. So the first part is we breathe in through our nose, and we're going to bring our arms in. Right. So we're bringing everything we want in the world in, and then on the exhale, we're going to make a ha sound and just get rid of everything that we don't want. Yeah. So you can do it as much or as little as feels right for you. Now, if you have a history of seizures or it doesn't feel good in your body to exert a lot of energy, you can always make a quiet ha sound, okay? So we're going to do it about 10 times. And if it feels all right with you, I actually invite you to stand up so that you can really experience what this is like, yeah? So the invitation is have your feet kind of planted on the ground and have your knees kind of soft, yeah? So we're going to inhale through our nose and exhale. Again. You're halfway there, come on. Almost. One more. notice what you notice. Any sensations, sometimes emotions come up. And just starting from your feet connected to that surface, moving up to your calves, to your thighs, or hips, just noticing what's here. Maybe there's a little tingling, a little buzzing. To your abdomen, your chest, your shoulders and your arms, maybe to the tips of your fingers. Your lower back, upper back, back of your neck, scalp, crown of your head and your brow, your eyes, your cheeks. And just noticing what you notice. Without judgment, we're just welcoming whatever's here. Yeah? I'll invite you to let that go. You can have a seat. So, again, that's a practice if you need a little jolt, or if you just need to just let something go. It's really a safe way to release the frustration, the anxiety, the overwhelm that is not uncommon when we're dealing with a chronic condition, yeah? Okay, next slide. So my intention is really to shed some maybe light on why our skin reacts to stress in the way it does, my personal opinion of the missing piece in most skin healing plans, and then we're gonna go through some more practices so you leave here with a toolkit of practices that you can use to help navigate the stress, yeah? So I think now being in this community for a while and, you know, all the presentations and getting to party and connect with each other, I'm hoping that you don't feel so alone in this journey. But if you've ever felt alone, I just wanted to name and normalize that across the board, when surveys have been done, 98% of people with chronic skin conditions says that it impacts their emotional well-being. 88% have named that it affects their personal life, almost that same amount affecting their professional life. 85% of individuals living with chronic skin conditions report that their mental health issues are stemming from living with their condition, yeah? And when it comes to HS specifically, 69% of patients surveyed are more likely to develop new onset depression, 48% more likely to develop anxiety than their counterparts. And from what we've come to understand, suicide ideation and risk is a lot higher in the HS population. So while these numbers are staggering, I hope they help you understand that you're not the only one if you've ever felt any of these things. Next slide. Because you know better than anyone that living with HS means living with constant uncertainty, right? The uncertainty of when those flares are going to occur and how much. It's not if they're going to affect your worth, your relationships, your capacity just to maybe get out of bed and get dressed, right? It's when that happens. How bad is it going to be? Am I going to be able to navigate this? So there's the pain, there's the physical discomfort. And then I know so many of you have experienced the medical trauma, being dismissed, maybe going years without a correct diagnosis. So it's not just the physical symptoms, yeah, but the ongoing distress of the unpredictability, which can significantly impact sense of self and create feelings of shame and isolation. Next slide. And so your body, including your skin, isn't overreacting. In fact, what's really happening, it's overwhelmed by all of it. And I know that it may not feel like it, but your body is not trying to betray you. In fact, it's actually doing its damnedest to try and protect you. And admittedly, I acknowledge that it does that in a way we would rather it not, by producing inflammation and pain and scarring and all of that. But it is doing the best it can in the only language that it knows. So every flare, every change in texture or tone that won't seem to heal is really our body's way of saying, whoa, 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 something isn't right here. And can we slow down enough to get curious about what that might be? But in our current medical model, in our current society, we've been told, basically conditioned to shush the messenger. We use scrubs, we use topicals, we use creams, and it might suppress it a little bit, quiet it a little bit. But unfortunately, we're not addressing what's driving those messages in the first place. So they tend to get louder when we're not paying attention. Next slide. Because the truth is, your skin isn't just some static surface. It's actually a storyteller. It's a living billboard broadcasting what's happening beneath, yeah? In your body, in your mind, in your nervous system. So here is something I wish every person living with a skin issue knew, because for some of you, it might change everything, yeah? Your skin isn't misbehaving. It's actually messaging. It's the part of you that's wired into the exact same network that controls your heartbeat, your breath, the flush in your cheeks when you feel seen, exposed, or vulnerable, and also the pain that keeps you from fully engaging in your daily life. Next slide. Next slide. Perfect. Because your skin and your nervous system are intimately linked. They are derived from the very same embryologic layer, the ectoderm. And together, they are part of a living complex network known as the NICE network. Your nervous system, your immune system, your skin, and your endocrine system are all talking to each other all the time, yeah? And they do that in an effort to coordinate responses to stress, to injury, to inflammation, to try and maintain some sort of balance. So all of those flare-ups, they actually aren't random. They're communication, yeah? Next slide. And it's our nervous system that actually is acting as command central. So our nervous system tells all our other systems how to respond. So it kind of acts like our own personal surveillance system. It's always scanning for cues of safety or danger because its primary job is to keep you safe. Now, safety doesn't mean the absence of threat. This is why I love the name HS Connect. What safety means is the presence of connection. Connection to self, connection to others, yeah? And because the nervous system's job is to keep us safe, if it picks up cues of danger, whether that's a car swerving at us in the street or subtle everyday stress, like someone's snarky comment or an inbox full of emails, or the absence of understanding and loving kindness from the people we encounter in our lives, it tells all the other systems to go into defense mode, which means our immune system ramps up inflammation. The endocrine system pumps out stress hormones, yeah? So hopefully you'll see that all these comorbidities aren't so random, they make sense for a system that is feeling like it's under threat and goes into defense mode. Next slide. Now, where this gets really fascinating is your skin isn't just part of this NICE network, this neuroimmunoendocrine cutaneous system. The skin itself is a neuroimmunoendocrine organ, which means it acts like your third brain. In fact, there was a recent paper that named the skin as our third brain. So we've got our primary brain in our head, the gut has been described as the second brain, our skin is the third brain because it has its own hypothalamic pituitary adrenal axis, a mouthful that basically means that our skin has the capacity to release stress hormones and inflammatory signals, which means your skin is both a target and a source of those stress signals. And so your skin starts to flare, yeah? And it does that because it is picking up cues, right? When we talk about what is creating those stress signals, well, our nervous system, the surveillance system, is picking up cues from 3 different pathways. Inside our body, so how tired, how hungry, how thirsty, how frustrated, how upset we are, our emotional state of being, and our hormonal balance, yeah? Our outside environment, the noises, the lights, the clutter, the toxins in our environment, and this one's important, the in-between, the relational environment, right? Where our relationships with others, where those present day moments can wake up old memories in our body, right? So our nervous system is reacting like what's happening now happened back there, back then, yeah? So our nervous system is picking up all of it, and our skin responds to all of those cues. And as a neuroimmunoendocrine organ, it has the capacity, right, to release those inflammatory signals, those cytokines, generate stress hormones like cortisol and adrenaline, and send those messages back to the nervous system, telling all your other systems to take action, leading to downregulation of next slide. Next slide. Downregulation of antimicrobial peptides, impaired wound healing, impaired collagen synthesis, stimulation of our pigment-producing cells leading to hyperpigmentation, dysbiosis of our microbiome, increased mast cell degranulation, which releases histamine, right? So all of these things, so slow wound healing, increased irritation, increased inflammation, increased itch, increased pain, stimulation. Cortisol directly stimulates our oil gland production, right? So contributing to blocking hair follicles, contributing to acneiform-like lesions, right? So when your HS may be flaring after a stressful week or a stressful period in your life, it is not just in your head, it is in your physiology. So the invitation is to maybe consider, instead of asking, what is wrong with my skin? Why is it overreacting? To get curious instead about what has it been carrying for so long? Or what do I need to do to feel safe or safe enough in this moment, right? Because safety isn't the absence of threat, it's the presence of connection. And admittedly, right, when we are living in a state of distress from the pain, the emotional toll that HS may take, right, we are looking for any way to soothe that discomfort. And I get it, right? We need an escape route. And oftentimes, the coping strategies that we might use, overeating, over drinking, over scrolling, unfortunately, the consequences could be contributing to the inflammatory process, yeah? And sometimes, we may direct that frustration at ourselves, hair pulling, skin picking, lip pulling, all of those things. And I just want to normalize and name, those aren't flaws. Your body is so wise that it's trying to figure out any way to create a sense of control in a body that feels chaotic. So the invitation is, can we offer different strategies that can create cues of safety, or at least safe enough, so that we can create the conditions conducive for healing. Okay, next slide. And then one more, sorry. I am using mine, but not offering it to you. Because if we don't create different strategies for ourselves, we can get stuck in this vicious loop where there is a stressful event, activation of the stress response, right? Skin is both a target and a source of it, releasing of stress hormones, creating flares of our condition, which can lead to anxiety, shame, isolation, overwhelm, creating more stress, and we get stuck in this loop, yeah? Next slide. So to understand how to restore a felt sense of safety, I think it's really helpful to understand how our nervous system works. And I love to use Dr. Stephen Porges' polyvagal theory to help explain this, because he has created a very eloquent way of understanding how the autonomic nervous system and the vagus nerve help to determine how the body functions, both physically and psychologically. And so I'd like you to imagine that your nervous system is like an elevator that moves between floors. Each floor is a different nervous system state. So the top floor is the penthouse, and in this ventral vagal state, this is our social engagement state, right? We feel connected, we feel resourced. Stress may happen, but it doesn't overwhelm us. We can handle it. We can ride the waves of stress activation and be okay. This is where all the communication within the NICE network is optimized, creates conditions conducive to healing. Now, if cues of danger come in, the elevator moves to that middle floor. This is activation of our sympathetic nervous system, our fight or flight response. We are mobilizing to take action. This is what we want. We want to be ready. We mobilize energy resources. Our glucose goes up. Our mind starts racing. Our heart rate starts racing. We are ready to take action because stress hormones are released, inflammatory signals are released, but this is also where we may see acute flares of condition. Now, we can only fight or try and flee for so long because it's metabolically expensive. Yeah, at some point, it's like holding up a boulder. At first, that rock, we're strong, we can do it, but after a while, we start to falter. And so we shift out of this survival mode if cues of danger keep coming in, and the elevator moves down to the basement, and we go into conservation mode. And this is where we go into a state of shut down and collapse. So instead of mobilizing energy, we start to slow down and immobilize. This is where instead of feeling anxious, we might feel depressed. We see chronic fatigue. We see chronicity of disease. And this is where suicidality and feelings of helplessness and hopelessness may arise. Now, I want to normalize and name none of these states are better or worse than the other. We need all three, right? We need to be in our sympathetic state to play and to dance and to be creative. We need to be in the basement sometimes, and we need to rest and repair. And there are hybrid states where, being in the basement with a little bit of penthouse is where we have that intimacy and the snuggles, right? There is no better or worse state. The goal is to have fluidity and flexibility to move between floors to be able to appropriately respond to what's coming at us. The challenge in conditions like HS is that often we get stuck on those bottom floors, and the body, the skin, doesn't feel like it has a way to repair. Next slide. So what is actually happening when your flare-ups happen, right? Whether it's, or even at the time of diagnosis, right? There's the medical misdiagnosis, like the shame, the stigma, all of that. The lack of this is a unique situation, but before this event, I would imagine there are many of you that maybe had never met others or been able to openly talk about the struggles. All of those are interpreted as cues of danger to the nervous system that keep us in those lower floors. Next slide. So how do we help our elevator start moving again with a little bit more fluidity, a little bit more flexibility, yeah? Next slide. This is where the vagus nerve comes in. Now, many of you may have heard of the vagus nerve. The vagus nerve is part of our parasympathetic nervous system, that rest and digest part of our autonomic nervous system that acts like a brake. The sympathetic nervous system is kind of like the gas pedal. The parasympathetic nervous system is like a brake. The vagus nerve is a significant component of the parasympathetic nervous system. It's kind of like our nervous system's communication superhighway. And it originates at the brainstem, and it has branches that are in connection with the cranial nerves of the face, our ears. It innervates our throat, our chest, goes through the diaphragm, and spreads out like spider webs and innervates all the organs of in our belly, right? All of our organs. What's really important to understand is that greater than 80% of those vagus nerve fibers are sending sensory information from the body to the brain. The brain uses that information to control digestion, our heart rate, our emotional state, and our hormones, which means our body is telling our brain what to tell the rest of our body what to do. So the current medical model only deals with symptom suppression, and if you've been in therapy, usually it's just talk therapy, right? We forget to bring the body into the equation, but it's the body that's actually determining what we think, feel, do, and how our body's actually designed to function, yeah? So we gotta bring the body into it. It's both what we call a top-down and a bottom-up strategy. So we can't think our way out of stress. We have to show the body that it's safe enough to shift states. Okay, next slide. So, breathing is one of the most accessible tools we have to help create those shifts, right? Every time we take a long, slow exhale, we signal through the vagus nerve to the brain, I'm safe, right? That simple shift can lower the heart rate, lower the release of the stress hormones, quiet the inflammatory pathway. And like I said, I just came back from the polyvagal meeting, and there were really interesting, there's more and more science on this, that this isn't just woo-woo to make you feel good. We know that the vagus nerve plays a role, right, through this psychoneuroimmunologic pathways of calming the inflammatory cascade, which means all those symptoms that seem separate and disparate, they're actually all connected. So when we can bring intention to the way that we breathe, we can bring regulation into the autonomic nervous system, so there's a gentle oscillation between that gas pedal and brake. Because when we inhale, we naturally stimulate the sympathetic nervous system, and when we exhale, we stimulate the parasympathetic, that rest and relaxation, right? So next slide. What I'd love to do with you, and again, you can opt in or opt out of as much as I said you like, is to bring some of these practices forward so you can take them with you, yeah? Okay, next slide. And because I know I'm talking a million miles a minute, I love to shift gears by offering a little mind shift as well, by offering a poem. And I love this one by Bridget Anna McNeil called Remember. Remember who you are, not the shape others have put on you, not the story they handed you, not the lies or needs that were pressed into your psyche, not even your own imagined ideas of what you should be, but the real you, the wild, innate you that is breathing under all those should-bes, all those untruths. Remember the feel of it, the shape of it. Let it inhabit you, like golden weeds rewilding the concrete. I think a lot of us should on ourselves. And so let's quit that. Okay. So next slide. Okay, next slide. So before we dive in, the invitation is just to do a quick check-in. And the invitation is to just turn your attention inward in whatever way feels right for you. You can close your eyes, you can look away from the screen, and just check in. This will serve as your baseline, just to check in with your mind. Are the thoughts racing? Does it feel blank? Does it feel a little dull? Again, without judgment, we're just simply noticing what's here. Checking in with your breath. Oftentimes, when we're rushing through things, we may actually be holding our breath. So noticing if you're taking a full breath or maybe breathing a little bit more shallow, perhaps a little bit. Are you able to take a full belly breath? Checking in with your body. Areas that might feel a little tense, maybe there's some twinges of discomfort, but perhaps there's areas that feel a little bit more neutral, pleasant, yeah? Any emotions that may be present. If you're feeling excited, if you're feeling skeptical, if you're feeling irritated or annoyed, all of it is welcome. And then just checking in with your overall energy. If you're feeling a little lethargic or energized, right? We're just checking in. And just kind of keep that in mind of where you're at so we can circle back to it when we come to a close. Okay, next slide. So I'd love to introduce a few different breath practices. Oftentimes when we're feeling a little discombobulated, a really nice practice is resonance frequency breathing or balanced breathing. So I'm going to ignore this slide for a moment. The invitation is to inhale for the same count as we exhale. So for example, we would inhale through our nose for a count of 5. We would exhale for a count of 5, yeah? So if it's all right, you can join me. The first 2 I'll count, and then I'll let you count on your own because my count may be too quick or too slow for where you're at. So the invitation is to feel into where you're at, yeah? So the invitation is to breathe in for a count of 1, 2, 3, 4, 5. Exhale, 5, 4, 3, 2, 1. Inhale, 1, 2, 3, 4, 5. Exhale, 5, 4, 3, 2, 1. I'll invite you to take a few more breaths on your own counting. And if 4 breaths feels better, or 6 breaths feels better, find your sweet spot. And perhaps on one of those breaths, imagining your breath coming in and out of your heart center. Maybe thinking of something you're grateful for, being in this community, or just showing up for yourself. And just letting yourself receive that as you breathe in and as you breathe out. And just 1 or 2 more cycles in this way. And then we'll let that go. And just pausing just to notice what you notice with that breath, yeah? And if emotions come forward, right? Tears are just movement. The body speaks in sensation and movement. Everything in the body is moving, right? So whether it's buzzy energy, if it's tears, if it's a little shaking, right? It's creating the space to let whatever is here to emerge, to meet ourselves exactly where we're at without having to try and change it. There's plenty of other people in this world who will tell us to change things about ourselves. The invitation is, can we meet ourselves where we're at with care and compassion? Okay, next slide. I don't know where we're on time, but this other breath is a nice one where if you need a little energy and also relaxation. So the stair-step breath, on the inhale, you can imagine that we're climbing the stairs, and because the exhale is really what invites the turn on of that parasympathetic nervous system, we invite an extra long exhale as we descend the stairs to really invite that rest and relaxation response. So when I do this breath, I can't help myself but have my hands move for the count as we're inhaling. So we climb the stairs for a count of 4, and then we take an extra long exhale as we descend the stairs. So if you're open to it, we inhale. We can do that again. We can do that one more time. And with that extra long exhale, just notice any shifts. Notice what you notice. You can take that, and listen, this is like a buffet. This is what I would always say. You try things on. If it sucks, you don't have to go back for seconds. Okay, next slide. Now, this one, because the vagus nerve is coming from the brainstem, it's innervating our larynx and pharynx, we can leverage sound to activate the vagus nerve naturally. Singing, chanting, humming is a beautiful way to naturally stimulate the vagus nerve. So there's a few different breath patterns that we can use. Next slide. We can either say the word, the letter E, or a nice practice is the VU breath. And the way that this is done, this can be a little energizing. So this is where I trust that if this doesn't feel good for you, you can let it go. Some find it helpful to put a hand to the chest and one to the belly so you can feel the vibration. And the way we do this breath is we take an inhale through the nose, and as we exhale, we make the sound VU. And we let it kind of reverberate down through our chest and our belly. So it kind of goes like this. And then we allow our breath to return to its natural rhythm. I'm noticing that makes me feel a little lightheaded. If that happens for you, you can always pause. You're sitting in your seat. You can push back into your chair for a little support, a little containment. Does anyone want to try that? Okay, cool. All right, so we'll do it together. So inhale through the nose. Exhale. Just allow your breath to return to its natural rhythm. That one create a little bit of buzziness. Sometimes a lot of emotion may come up with that, right? You can always do that a few cycles, but in the interest of time, I'm going to let that go so we can just move on to one more practice. And this is where the power of touch. Your hands are the most powerful tool you have. And your skin is this beautiful, we have this beautiful sensory suit. So our skin is covered with thousands of sensory nerve endings that are tied directly into our autonomic nervous system and covered in special nerve endings called CT fibers. These CT fibers have been shown to directly communicate with the emotional regulation centers of our brain. If you've ever had a massage, that slow, gentle stroking that you're just like, oh, that feels so good, that's exactly what we can do for ourselves, right? We can create that release of oxytocin. Oxytocin, we think of as just the love bonding hormone, but I was just talking to Dr. Sue Carter, who is a pioneer in oxytocin research, and she has shown us that oxytocin isn't just a hormone of connection, it's an powerful anti-inflammatory and antioxidant, really important for skin healing. So we can leverage the power of touch to help not just soothe our system and feel a little bit more attuned and in balance and connected to ourselves, but really cultivate conditions for healing and get that elevator moving back towards the penthouse. So this is a really nice practice. Dr. Kate Truitt, next slide. Oh, next slide. Next slide. Okay, so Dr. Kate Truitt has done a lot of research on a technique called self-havening. And this is a wonderful practice that is done by gently and slowly rubbing the hands together, right? We can generate some warmth. Typically, we want to go like this to generate the warmth. I'm going to invite you to like slow it down a lot, slower than you think that you feels even humanly possible, yeah? So you can really feel that skin on skin, that connection. And then we're going to invite those hands onto our temples, our forehead, sweeping outwards, moving down to our cheeks, and just noticing what your body wants. If it wants more or less pressure, slower or faster as you move down your face, across your chin, your neck. You can even take it into your scalp. Your scalp is so rich in sensory nerve endings. Bring it to your ears. Your ears are incredibly rich in vagus nerve fibers. Your lobes, your tragus, inside your ears. Has anyone used a Q-tip and like just been like, oh my God, that feels so good? Like an eargasm, yeah? That is because you are stimulating those vagus nerve fibers, yeah? So we can leverage this just with our power of touch. Right, you're right, don't mind me. Okay. Right? And laughter is medicine. Laughter is, right? It's like, honestly, like trauma healing, stress, like healing doesn't have to be so serious, right? But we can use the power of our own touch, our laughter as medicine. So after we can gently massage, and you do this with your skincare products when you're washing your face, just slow it down, pair it with your breath, right? Your touch, every inhale, every exhale. The important part, the last step of this process, is a gentle sweeping from the shoulders down to the arms, right? It's kind of like anyone has done Reiki, right? We're sweeping that energy off, but it's that gentle downward motion that has been found to be incredibly important for activation of those CT afferents. It's the downward stroking motion, yeah? You can also add a little arm squeezes sometimes when we disassociate, when we don't want to be in our body, and we don't even know where we begin and where we end. We can use a little arm squeeze, leg squeeze, yeah? So just making more contact and connection, right? Safety isn't the absence of threat. It's the presence of connection, connection to self. Okay, next slide. And again, I was just mentioning self-holding, yeah? So squeezing, self-holding, giving yourself a hug. You don't need to wait for anyone else to validate you or give you a hug. Yes, it's nice when someone else does, and that's skin-to-skin contact. But don't forget that you can honor yourself with your own care and connection through a hug. Another one that's really helpful, and this is where I'll kind of end, is a head hold, right? Your head holds so much. There's a lot going on here, and it can feel like your head wants to explode. So a really beautiful practice is to put one hand on the forehead, one hand at the back of the head where that ridge is, and just give some support. I don't know, as soon as I do this every time, it's like my shoulders just drop away from my ears. And you're just helping offer some support because your head is holding so much. So this is a really nice one. And then you can let that go whenever you're ready. Next slide. I don't know how are we. What's the time? Okay, perfect. So self-compassion is always important, right? And the whole point is that every practice that we do is, can we do it without judging ourselves? To make space for everything that we're thinking, feeling, and experiencing, and making space for it. But I did want to bring in one additional practice, because I think, stress and the experiences that we've had, that they change the way that we hold ourselves, and posture can make a huge difference. Dr. Pat Ogden, the creator of sensory motor psychotherapy, has said that that posture are positions from which only select emotions and behaviors are possible. So I'm going to invite you to just do a little experiment with me. Everything is kind of like a lab, right? We see how it feels in our body. I'm going to invite you to think of a moment when maybe you felt like shame or small, right? That sense of curling inward, right? This naturally mirrors. Sympathetic is we open up, but the parasympathetic, that collapse. The parasympathetic can be a tap on the brake, but it also can be an emergency brake, yeah? So when we're feeling kind of overwhelmed, we oftentimes close in on ourselves. So I'm just going to invite you, maybe just fold your shoulders in, fold over for just a moment, and just notice what feels possible here. How is your breath? How easy is it to breathe when you're hunched over? Yeah? It's kind of uncomfortable, right? We don't feel capable of as much. So then I'm going to invite you to shift that from a moment where you felt supported or seen or like really confident, like opening shoulders back, like owning your badasseriness, right? This is like a group of incredible people here, and you have a lot to be proud of. You have a lot to offer the world. Shoulders back, and just notice what feels possible now with your breath. Yeah? And we can oscillate between the hunched over and then the opening. And if you do that a few times, just noticing, right, what feels possible, that restoration of our natural rhythm. We're supposed to move between the opening and the closing. The problem is so many of us get stuck in that closed position. But we can show our body it's possible for a different experience, right? It doesn't take much. These are things that we're doing 30 seconds to a minute at a time, but done throughout the day on a consistent basis, different cues are being sent to the nervous system. Cues of safety or cues of safe enough. Even while you're having a heated discussion with someone, if you feel your feet planted on the ground, right, you can remind yourself, shoulders back, I can breathe. Or maybe just a hand of self-contact, reminding like, your skin is your boundary. This is one that I taught in the group. A nice one is hand under the armpit, right? Skin is your boundary. Boundary between you and everyone else, right? So this is almost like protecting me against you, but this arm is free. So I can engage with the world, but it reminds me, back up. This is my boundary. You stay where you are, and I got me. Well, I am engaging with you. It's a really helpful one. It's not defensive. It's protection and self-preservation. So with that, next slide. I would just invite any thoughts, any questions, any experiences of what was that like for you? Or, what you liked, what you didn't like, what you'd go back for seconds on, if anything. I know some of this may be new for some of you, but the invitation is this isn't an either or with medication. This is a both and. Because if we can send the nervous system, right, different cues, then it tells the immune system, the skin, and our hormones to quiet the alarm bells, yeah? So hopefully things can work better. Yes?
Hi. So I
before you'd mentioned the touch thing, it was really funny to me because throughout each of the sessions, in order for me to stay calm, what I do is I usually trace like the veins like across my hand, and so I thought it was really like that usually is super helpful for me, and so I liked that you incorporated touch and also like doing the havening,
yeah.
the havening, like that was really relaxing to me, because oftentimes what I will do is sometimes when I'm lying in bed and I'm stressed out, I usually will just like trace like any line that I see on my arm, I'll just trace it down, and that usually helps like center and like make me feel calmer. And so that I like that connection to it, and how it, in talking about the vagus nerve and knowing that it was connected to something else.
Isn't it so brilliant? Like, your body already knew. You have such inherent wisdom, and now we're just putting kind of the science with what you've known all along. That's the power of this. Like, you all have this innately in you, but we've been taught to suppress it. We've been taught to sit still, be quiet, when in fact our inclination is to hum, to sing, to trace, to touch. And so this is all just going back to basics, right? Just going back to basics. So I love that you knew that innately. Yeah. Anyone else? Yeah? And then I'll have you do the next slide just to have it on the screen, please.
Yeah. Oh, by the way, your voice is awesome. Like, if you had like a YouTube video with that, I'll listen to it at night and go right to sleep. But but nah, like really practicing those breathing techniques, like instantly I was feeling like I was getting calm, because like just recently, the past few days, mine been going crazy, feeling it in my body. So like I was actually practicing, and, almost coughing, but I really was feeling it though. Like, and I'm like, it ain't gonna work. But when I really tried it, I'm like, I'm gonna really incorporate that throughout my day, because I really like that. So thank you for, putting me on. Yeah.
For real.
I just want to offer that, I want to make this actionable. So this is a guide, a free guide that you can download that gives you it gives you kind of an overview of what we talked about, the nervous system elevator. The nervous system elevator, and then 3 simple natural vagus nerve stimulating practices that you can do. So you can have it in your pocket, you can do it anytime, anywhere, because I want you to take this with you. Because yes, I was like you, I was like, this is bullshit, it's not gonna work. And it changed my life, and it changes the way I practice now, so thank you.
Thank you so much, Dr. Barr. Absolutely. Yes. Practice these things. The breathing techniques, doesn't matter where you are, if you control your breath, it's the quickest way to trick your nervous system that you are safe, and it is a very effective way of managing stress. Because you can't control life, but you can always control your breath. Think about it that way. Okay, we're going to take a quick little break, and 10 minutes, and then we're going to come back. We're going to hear a word from Whitney and Ray and their amazing products, and we're going to have Tatiana for sex therapy. And then we're going to finish the day off with a lovely talk from Anne from Novartis and the giveaways. So, 10-minute break. Be back at 3 o'clock. We got 3 o'clock. we are going to get started with the last segment of the day. Thanks, guys, for hanging in there. I know it has been a very information-dense day. We've learned so much. I think it was really great to have Dr. Barr's presentation and a little decompressing, so we're nice and relaxed. So to finish out the day, we've got 3 things. We're gonna have a quick talk by Whitney and Ray. You've seen them outside. They are part of the HS community, Asians patients as well. And they are gonna talk to us about the CPC ritual, which I personally was able to test, and I'm a fan, I'm just saying. There you go. You know Shakira likes it. You go, girl, you got this.
Hi, everyone. Not nervous at all. Well, my name is Whitney, and this is
Ray.
Before we get into this, we're gonna practice pronouncing something. So we're gonna repeat after me. Su, Laj, Ma, Sulajma. Oh my gosh, that was so easy. One more time, Sulajma. All right, so that's the name of the place you're gonna be getting your favorite products. Sulajma.com, but the company is sulajma.life. Well, Ray and I've had HS for over 20 years, and so have you.
Same.
And for about 15 of it, I did not have health insurance. My first flares came, I was very new to America. I am Haitian, and I didn't know much about the system or how things work. So there were some things I was never gonna be able to figure it out, and my family wasn't very helpful, so I had to take healing into my own hands. Eventually, my journey led me to India, where I studied under this older Ayurvedic healer in a small village, and she taught me the basic and foundations of a lot of herbs and oils, how it could help me. Now, I didn't know I had HS, but I knew it was inflammation, so I was able to work from that. I feel very nervous. Like my voice is shaking. Right?
Breathe, you gotta breathe. We just
I gotta breathe. All right.
Yeah.
So I've been working on this formula for 10 years. It honestly started with coconut oil and tea tree. Eventually, the more I learned, the more I changed it and worked on it. And now today we have the CPC ritual: cleanse, promote, and comfort. Because different cycles of the flares need different care. We can't have one product to do it all. It's possible, but sometimes you need different things for different stages.
So I present to you cleanse. The energy intention behind the cleanse is to wash away what no longer serves you, so your body can breathe again. It's called Vana. This gentle plant-based wash clears away buildup and bacteria without drying out your skin, packed with herbs that calm irritation and prep your skin for healing. Think of it as the reset button, a way to rinse off the day and the heaviness that comes with it. So the instructions are to apply to dry or damp skin, let sit for a few seconds, and then wipe away gently. Rinsing is optional.
They are all safe on open wounds.
Promote. Next slide, please. Promote. The energy intention is to promote the release of pain, tension, and old energy, called nirvana. When a flare starts to feel angry and or tender, this blend steps in. Made with slow infused herbs and rich oils, it helps draw out inflammation and protect the skin while it heals. Promoting the release phase, a deep exhale for your skin and spirit. The instructions: after cleansing with Vana, place a few drops in or onto the area that needs care.
I have absolutely dropped a few drops inside of a flare. So it is safe, it's not gonna stain, it's gentle.
And comfort. The energy intention to comfort your skin and spirit, sealing in peace, patience, and self-love, called Shivana. The soothing phase. The moment your skin starts to reconnect, it helps you finish strong. Made with nourishing oils and calming herbs, it softens scars, seals in moisture, and reminds your skin that the worst is over. Instructions. After cleansing with Vana, massage onto clean, healing skin. Do not apply if the skin is still draining. Patience is the key with the last one.
It really is, because you going to want to move on to Shivana most likely a lot sooner than you should, because that's happened for me. I'm like, okay, now I'm ready for it to stop draining. Sometimes we need to let it fully drain so it can really heal. And I also want to say that this ritual can be used with any plan of care you have going on. Don't feel like because you're on biologics, you can't take it. This is just to help. It's not a cure. And if you are on lifestyle modifications, you could use it. Regardless of your plan of care, this will be your buddy, your best friend to keep around.
Thank
Any
you.
questions?
Oh, yeah, questions.
So I'm going to say it depends on your situation. Like, please do let the wound breathe, because that helps it heal. But if you're going out, sometimes you might need to put a Band-Aid on it. Okay. But it is totally fine if you just let it breathe. Yes.
Thank you.
Today, each of these small bottles are $20, but that's just for Empower HS. And the full set is $50 together. After that, there'll be like some HS Connect discounts, but the prices will be different out of here. That's all I want to say.
Thank you so much. November 11th. Woo! Awesome. Is she ready? Okay. Okay, everybody. We have our next speaker.
Thank you so much. I am thrilled to invite Tatiana Arias to the stage. By trade, she is an intimacy coordinator for many a show on big networks such as Hulu and more. And we are going to strip away some of, I know, we're going to strip away some of the secrets and the shame behind sex with HS and learn how to have fun and be comfortable. So thank you very much, Tatiana.
Thank you, Andrew. Thank you, everybody, so much for being here. Thank you, Brinley, for putting this all together. It's so exciting to meet a lot of you that I've never met in real life in person. Me and Christina have known each other for ages, and this is the first time we've touched. Was here. Can you all hear me? Okay, cool.
Yes.
I'm not used to the mic thing. All right, so I know it's like sex therapy on the schedule. I just want to do a little disclaimer. I am not a licensed sex therapist. What I am is an intimacy coordinator and an intimacy specialist for many years. And I'm also an HS patient. I have had stage 3 HS. I've had HS symptoms since I was a toddler. I am inactive in a lot of areas right now, but you guys know from the scars how severe it was. I'm sure you can tell. Do I have a clicker, or do I just say next slide? Oh, yeah, maybe, because I'm a little walker, yeah. Can we do next slide? Thank you. So just a little background, a little street cred, if you will. I've been an intimacy coordinator for film and TV for over 5 years now. You can check out some of my films on BET Plus or on Hulu and other places. I've had stage 3 HS for over 30 years. I'm 42 years old now, and I've had boils since I was a toddler. I am an HS advocate, educator, and workshop facilitator. Me and Christina have had HS and intimacy calls that I would love to bring back with you guys. We're in the works about bringing them back in some capacity so that we can have these intimate conversations continuously. We can go on to the next slide. Okay, so I want to, in general, talk about some issues that are faced with HS and intimacy, and then I want to go in a little bit about my personal story. So some of the issues that are faced with intimacy in general, but specifically with HS and intimacy, are physical pain and discomfort. Sometimes from active flares, active draining flares, literal pain that we have in our body. Other times it's not active flares. Other times it's the scars, discomfort from being triggered in a certain area. I have areas that are inactive, but I've been so used to being in defensive positions that sometimes you react even if you don't have something in that area. So physical pain and discomfort can change from day to day, from person to person, depending on what stage of HS we're at, how we're feeling that particular day, all of that. So we'll get into that a little bit more. Confidence. HS affects our confidence too, whether it has to do with how you feel about how you physically look, or also about smells, pain, discomfort, again, that can affect your psychological well-being and how you feel about presenting yourself, even in an intimate space. It doesn't matter if how the other person feels at all. If you are not in the mindset to get yourself into a sexy space or an intimate space or a sensual space, it's hard to get out of that through the physical discomfort and the confidence. Communication is another issue. A lot of us have the big question like, how do I say it? When do I say it? To who do I say it? Is it something that I'm bringing up on the first date? Is it something that I'm bringing up on the wedding night? Like, how late are we talking about this, you know? So some reflection questions for you guys to think about just now before we even get into how to work with this is, looking at these areas, and think about it right now, if you have your notebooks, maybe jot some of this down. How does this show up in your life? How have you had moments where your physical pain and discomfort has affected your confidence, your sexuality, your interaction with a partner, your interaction on a first date, your desire to even date to begin with? What are the areas where this has affected you? And what's most important for you to address at this time? Are you having trouble with communication with your partners, and that's something that you really need to work with, and you're okay with yourself, you've accepted your scars, you've accepted your pain? Are you in a moment where you have to reassess what feels pleasurable to you? Reassess like where your body is at, how you want to engage in relationships from now on. So I just want you to think about that a little bit. We can go to the next slide. So these were gonna come up individually, but I wanted to talk a little bit about my journey with confidence and with my scars and in general with HS. So that's little me in Colombia at like 3 years old. She had golf ball size flares. That little baby had golf ball size flares on her thighs, in her armpits. My mom used to take me to the doctor and drain them. They had no idea what it was. Cut to living in Miami. This was me in like middle school or high school. It's hot as fuck in Miami. It is humid. Why am I in a black big ass t-shirt and a skirt? Look at this other picture. It's from like later in college. I'm in Texas in this picture, in the middle of the summer. And I'm wearing tights under my dress with a shirt on over the thing, because I wasn't doing this. I'm not wearing a sleeveless shirt. I wasn't going out like that. I was a confident girl. I've always been confident about my weight, about all those things. The one thing I wasn't confident about was my scars. It felt like something was wrong, and especially because at this time, I still didn't know what the hell it was. Doctors were putting me on antibiotics. They were putting me on birth control at 12 years old. And nobody had still said the words hidradenitis suppurativa to me. It wasn't until I was 18 at a nurse practitioner's office in Tallahassee, Florida, where I went to school, that I was having a pap smear. And the nurse practitioner said, these marks under your thighs, he's like, do you also have them under your arms or like under your breasts? And I said, yes. And he said, do you know what it's called? It's hidradenitis suppurativa. That was the first time I heard those words. And he took me to the back office and pulled it up on his computer and Googled it and showed it to me. And I was like, we're healed. He knows the name. Like, it's done. It's over, right? Like, we know what it is. Give me the pill. And I went to my doctor, super excited, and they Googled it in front of me. And so for the next 10, 20 years, doctors Googled HS in front of me. And I was telling them about this condition. And I know a lot of you, how many people have experienced that? Where you're telling your doctor what HS is. That sucks. I'm sorry, I see you, I feel you. Years later, and this is how me and Christina met eventually, I found the online HS community, which at first was kind of lumped under the autoimmune, anti-inflammatory food space. So I became known as Fat Girl AIP on Instagram, and we kind of found each other under that umbrella. And changing my diet, I don't want to spend too much time on the AIP thing, but AIP changed my life, and it took a lot longer than I thought. I read somewhere once that it takes a month for every year that you've had a condition to reverse it. And to me, that's 3 years, because I've had it for 30, at that point I'd had it for 35 years plus. So I was like, you know what, at least that gives me a number. Because when I first started AIP, it got worse before it got better. As your body's like clearing this stuff out, I had worse flares that I had had since puberty. I had days where I didn't get out of bed for 2-3 days. My best friend that's with me here tonight put my underwear on one day because I literally could not. And it took a long time before it got better, but it did. And you can see that I have a lot of areas that are completely inactive now. That doesn't mean that I don't have areas that aren't. I have a lacy bra that I only wear if it's coming right back off. And last night, I decided I wanted to be cute and wear it to the party. So I wear a normal bra for 3 hours. And this morning, I woke up with 3 flares under my boob. So like risks, you know, you take your risks. So like I said, discomfort and pain and confidence can change from day to day. What was a green zone for me yesterday could be a red zone for me today, you know? So eventually, I got more comfortable with my bodies, with my scars. AIP helped me talk about it more because when people would see the way that I would eat, then they would start asking questions. And inevitably, I had to start talking about why I was making those choices. And it led me to talk more about my skin. And it also put me in the driver's seat where for the first time I felt like I had some control over something. And so I felt more empowered to talk about it. And I felt like I was coming at it from a different space. So these are just some pictures later. And this is an important picture, the bikini picture, because the first time I put on a bikini, and I was worried about these little scars that you could see underneath my boob. And I showed it to my friend, and my friend's like, what? Like, I'm looking at so many other things. I'm looking at titties, I'm looking at your butt, I'm looking at your hair, like, look at these shoulders, like, what scars? What are you talking about? But that's what we see, because we zoom in on that. So my biggest advice to you is to zoom out, and we'll talk a little more about that. So next slide, please. Okay, so tools for opening the door to deeper intimacy. One of the things that, like I said, it starts with yourself. We have to get to know ourselves again, what feels comfortable, what feels pleasurable, and learn to understand that before we can communicate it to a partner. So one of the most important things, like I said, is zoom out. A lot of the times when we're looking at our scars, we're either looking at them or taking photos up close. I'm zooming in, I'm trying to squeeze, I'm trying to look at the thing, and it feels like it's so big. It feels like it's your whole body. Like there are days where you wake up and you feel like you're a walking freaking flare. You know what I mean? Like people can see it on your face. And that's not true. How have you felt when you're meeting each other in here? Think about the first thing you notice about someone when you've met them here today. Think about the second thing. Think about the third thing. Think about the fourth thing. Have we gotten to a scar yet? I could barely hear what Hannah was saying because her eyes are so gorgeous when I was talking to her. There's 100 things I notice about Andrew. There's 100 things I notice about Christina. I've never thought about a scar in the interactions that we're having here. Have you? Unless we're talking about them. That's how people feel outside too. So zoom out. The same way that you're looking at other people, please, I encourage, I invite you to look at that way at yourself, to look at that way in the mirror. Start taking pictures where your scars are visible, where they're not the focus, but like where you're in a nice, pretty dress, and you can kind of see a little bit of scar in the corner. And start taking a picture like that. And even if you don't post it on social media, look at it. Flip through your phone and look at it. Start actively doing the exercise of pointing out the other things that you see. Pointing out your pretty hair. Pointing out the shoulders that you like. Pointing out the curve of your hip, your nail polish. It might be hard at first. You might have to be like, I like my glasses. Like, you know what I mean? Start where you can start. But I encourage you to do that exercise and do it over and over and do it in the mirror and do it with other people. Do it here. Think about what you're noticing about each other when you're walking around. Okay, cool. So take sexy photos where your scars are visible. Like I said, they don't have to be the focus, but just where, you know, I used to have pictures that were gorgeous and you could see this tiny little thing. And I was like, burn it. Burn the photo. Now I'm like, I don't even see that when I look at a photo of myself. So another tool that I use in my intimacy coordinating with film is our body scans. So I do these with actors before we choreograph an intimate scene, just to get a vibe of like what's on and off limits. I've done scenes that are pretty intense and intimate. If you check out Three Ways on Hulu, you will see that there are some pretty intense scenes. So we'll do a body scan, because even if you don't have HS, every single person has something that they are uncomfortable about, some place that might be painful today, some place that they don't want touched because their boyfriend doesn't want them, whatever the reason might be. So we do body scans. That's one of the first things I do. So I want to do a little body scan with you guys today. So that way we can get used to doing it for ourselves, and it's something that you can also eventually do with your partner. I kind of want to walk over here, but I don't want to stand for another thing. Okay, so I want you to think about like a street light. Green light, yellow light, red light, right? So you're gonna go through just your whole body from the tippy top of your head. And when I'm doing it with actors, I'll have them do it in front of each other and actually like show on their body the areas. But you guys can do it mentally. You can do it with your hands if you feel like it. You don't have to say it out loud. I just want you to think about it and like assess your body. You can close your eyes if it feels easier. So we're gonna start with the top of our heads. For me, the top of my head, and my whole head is green. Nothing hurts on my head. I like being touched on my hair, my head. So for me, my entire head would be green zone. If we were choreographing a scene, or if I were talking to a partner before an intimate encounter, I would be like, head, go, like anywhere. Shoulders, arms, also green. My underarms, red. You know what? I don't have any active scars. It doesn't hurt. I'm not bleeding. It doesn't smell. It's none of those things. It's just an area that for me, number one, does nothing for me. What are you gonna do to my armpits? Number two, it takes me out of my body and puts me in my head, because it reminds me of my scars. It triggers memories of pain sometimes. It triggers memories of insecurity. So that's fine, it's a red zone. Even if it's not active, it's a red zone for me right now. You don't need to touch my armpits. Okay, so then moving on. This would be a green zone. This is a green zone that I love to be a green zone. Today I woke up with 3 flares on my left boob. So you know what? You could do red zone this whole area. Not me, baby. We're saying yellow over here. Proceed with caution. And green over here. This is fair. We're still good over here. You know, that's why God gave me 2 of them. So. And then moving down, stomach, fine. I'm not self-conscious about my stomach, but some people are. And it doesn't have to do with scars. It could just be like, you don't want somebody to grab your little fat. I like it. I think it's cute. Grab my fat. Whatever. I used to have, and you can see them in this dress, which is why I wear this dress. I used to have really bad HS on my little fat rolls right here. So that would have been an area that I wouldn't want to be grabbed, even around my waist. Now I forget that the scars are even there. So green zone, all the way across, green down here. Getting to our hips. Green on the outside, green on my hips. My butt changes day to day. So that might be a zone that for you on some days might be yellow, on some days might be red, on some days might be green. I actually had a conversation with someone yesterday, and I won't say the name, but if you want to share, you can say that it was you. But they were talking about how their husband likes to spank their ass. But she's like, I literally don't know if it's gonna be a day where I have a flare and you're gonna smack my ass and hurt me. And I'm not gonna go through the thing with you every day of like a news flash of today is an ass day, today is not an ass day. And I'm like, but you know what? There are things that we can use and tools that you can use. If you love getting your ass smacked, you're gonna think that you're gonna miss out on that for the rest of your life. Pick a special pair of shorts. Pick a red pair of shorts that you tell your husband, if you're wearing those red pair of shorts, then it's fair game. You can smack my ass all day. And you know what? Every time he sees that pair of shorts, he's gonna get a little bit excited. In the morning, you know what I'm saying? And then it takes the communication out of it. Sometimes out front verbal communication can feel a little unsexy. And that's okay, we can find little workarounds to it. Like that, for example. Okay, cool. So did everybody get the idea of the body scan? Were you guys feeling the thing? Okay, so then groin, like we'll just finish it out. So in my groin, I don't have anything active right now, but it's still an area that for me is triggering sometimes. When a hand starts going up my thigh, sometimes I instinctively will close up. Because I'm used to covering the area, because I'm used to maybe experiencing pain there, because it's a memory that the body keeps the score. It's a memory that your body has. And we're used to defensive movements. I could pull my hair in a full bun without raising my arms. I know how to put my hair up like this. Do you know what I mean? And those things come into play in the bedroom. We do that in the bedroom too. We hide ourselves, we cover, we do those things. You get out of your body and into your head. So it's the practice and the exercise of getting back out of your head and back into your body. Cool? Okay, so body scan all the way down. Legs, oh, I was gonna say, my neck is yellow. And that's because I'm ticklish. It has nothing to do with HS. It has nothing to do with anything. So body scans are helpful even if you don't have HS, because sometimes you just want to say, like, what's fair game and what's not. Legs green, toes green, all that. So does everybody get an idea of what a body scan is? Did you kind of loosely do it as we were going through it? Do you feel, does anybody want to share any areas that you became aware of? Or maybe had some things that you hadn't thought about in that moment?
Well, I'll share. So I'll share that, like, an experience, because again, inner thighs can be it used to be super red for me, or like, oh my God, like the same thing, that like the hand up the thigh, and I still have those moments. And tying in Dr. Barr's practice, something that I've learned, because like right now they are green. I don't have pain. A lot of you know, but I've tattooed over my scars, so like, but I have to, in that moment, almost like, like relax, and then I can enjoy. And it was like I was at the big old age of like late 30s when the first time I like thoroughly enjoyed having my partner in that area, like, you know, with lights on and all that. So sometimes you have to reprogram yourself in the moment when it's a green day, but you're still remembering the red.
Yes.
Just sharing.
Please, that is so important. So yes, sometimes you have to call yourself back. It's okay to have those moments where you get pulled away into your head, but start being aware of it and start trying to pull yourself back into your body. And if you have a partner that you can trust and you feel comfortable with and you've established this open communication with, you can talk to them about it. And if they know you, they'll be aware when you kind of come out and come in of your body. And you can find grounding practices together to bring you back. Cool. So we can go, okay, with partners. So one big thing that I can tell you is when speaking to partners, no matter when you say it, no matter when you choose to say it, and this is speaking to partners, speaking to family, speaking to friends, people match energies. I'm going to say it again, and you better write it down. People match energies. When I first started eating AIP, I would, when I started going to restaurants again, when I felt comfortable going to restaurants again, I would bring like sauces, or like, I'd go to a Mexican restaurant and bring like plantain chips with me. And the first time I did it, I went into the restaurant, and the waitress came to the table, and I was like, excuse me, I'm sorry, I have some food sensitivities, and I like was wondering if maybe I have a sauce, and like, can I use it with my thing and the thing, and then maybe, and she was like, I don't know, I have to ask my boss, I don't know the thing, I don't know if I could do it, maybe. And now I go to a restaurant and I plop my coconut aminos down on the table, and I'm like, hi, I have some food sensitivities, but I brought my own sauce, and don't worry, I already looked at the menu. And the waitress is like, okay. Because like it feels like I know what I'm doing, like I know the owner or something, so they match your energy. Same thing with partners. If you are talking about your HS with shame, with sadness, with fear, with disgust, which all of us have experienced at some point, they are going to feel like there is something to be sad, ashamed, disgusted by. If you approach your own HS with love, with curiosity, with gentleness, and you say it that way, that's how people will receive it. I promise you. It sounds scary. I know. But that is how people will receive it. So I encourage you to start looking at yourself, and events like this and the community that we've built, that we're building, helps you look at your HS in a more loving way. And I think even being here at this event and seeing so many of us in person will help you see your HS in a more loving way, because you've humanized it now in other people, which is sometimes easier than humanizing it in ourselves. So I hope that you'll carry this feeling with you when you talk to your friends and partners about it. Body scans and roadmaps. So you can do a body scan with your partners. Do a joint thing. They might enjoy it too. You don't know if some of your boy ripped his ACL and needs to talk about it. You know, there's places you can avoid with men too, with your partner, with women. So talk about the body scans with your partners. Give them a roadmap. Like I said with this, left boob's off limits, everything else is fair game, let's go. It doesn't have to be a longer conversation than that. Once you're established with a partner, that's all it has to be. Like, red, go, you know? Clothing, lingerie, use it to make you feel more comfortable. If there are still scars, still things that you are uncomfortable about showing, things that put you in your head and take you out of your body, use lingerie to help yourself feel more comfortable. There are things that you can buy that have coverage, and you can buy crotchless chaps, if that's what you feel, that will cover everything except anything you need out. You use the lingerie, use clothing to make you feel sexy, to put you in that space, and to make you feel more comfortable in your body if you need it. We can go to the next slide. Oh, well, okay. Go back to the other one. Just kidding. Okay, cool. One story that I wanted to tell. One of the first times that I was with a specific partner, we had been dating for a while, and I had a flare on my boob. And it was high enough that it stuck out of like my shirt line. And I was like, we have a date tonight. Like, I have a bandage. He knows about my condition, but he's never seen a bandage. I'm not in pain, so I don't want to cancel the date. And I also don't want to wear a sweater or wear a t-shirt. That's not me anymore. Like, Christina thought there's Tatiana naked again. I'm like, the only reason I wear this much clothes is because you brought me to Nashville. But I was like, I don't want to wear something that's not me. And so I made my bandage into the shape of a heart. And I put one of those clear, like, Taxiderm things over it. And I just wore my regular clothes. And so he came over, and I didn't even talk about it. It was just a little heart bandage sticking out of my shirt. And he was fine with it, and it made me feel better, and it also, like I said, changed the energy. People perceive how you present. So if I'm doing it as something cutesy, it's the same as the pimple stars. When I was a kid, you were not gonna walk around with a pimple star on your face. Are you kidding me? And now people are like out at the grocery store, like out at the red car, out at the thing, with pimple stars all over their faces. So, like, why not? Why can't I make a little heart bandage and put it on my titty? Like, people match energies. But I wanted to give you guys a chance to, like, ask some questions if you have any questions about anything specific. An hour is shorter than you think, so I was trying to hit some important points in it, but also know that we're running behind. I want to give you a chance to ask some questions, or if you want to hear me elaborate on anything. And if it isn't anything that I covered here, please reach out to me. Please find me online. I'm FatGirlAIP on Instagram. We do have a question in the back.
It's not a question,
Okay.
but when you brought up the like red shorts to use.
Yes.
My partner and I used to use, you know, those animals that flip out, and
Yes.
the happy side and the sad side. We had like color coordinated ones for certain things, and it was like, when that one's out, everything's good, it's a green light. You know, we had different ones, and there was like an angry one and a unicorn, and those are so fun, and you can just kind of, they look like decoration. It doesn't have to be something crazy, so we could just have those out, and I just really liked those in case anyone else is interested.
Yes, that's exactly the theory behind it. The little octopus that you're like, you would flip and it was red and it was thing. That's exactly the theory behind it. Use tools, use shorthand with your partners to signal those things. What's up?
I just want to say, as a guy, I normally don't talk about these things in public per se, but it's very important because I've been that person that that presented it in a way that would lead to somebody, like you said, you present it and it's going to be perceived that way. But I also noticed over time, as an adult, when dealing with new partners, the more that I learned about HS, the more I was aware of the condition and what it does and how it affects me. I was able to explain that to partners and they have no issues. The red flags that I think they're gonna see, they're only in my eyes because they're not worried about my flares. I put more emphasis on my flares than anybody ever has.
They care about you and they want you to be comfortable.
Yeah.
So
and
they
I
care
mean,
about that. They care about your flares in that sense, but that's it.
Yeah, and if anything, they want to help more than anything. So if they tell you, if you tell them, hey, I'm flaring right now, I have partners that say, hey, well, what do we need to do? If you just want to chill, let's chill. If this is the red zone, that's the red zone. Let's go green, you know?
Yeah.
And so over time, that made me more comfortable in, you know, but I've also caught myself, you know, basically like you know, the body scan and everything, when they get ready to come to that area where you know you got a flare, I even dealt with it in a sense of, I may not have flared there in months, but I know my skin is still kind of raised there.
Mm-hmm.
So at times when I want to have my hands back behind my head, I got one hand down here trying to keep them from going, you know, to that spot. And like I said, when you actually have open communication and you know, you take that spotlight that you think is on your flares off, you'll be fine, have you a good time.
Mm-hmm. Yes. One thing about that, so about having your hand there was one time where I had a hand and someone like was trying to move it, and then they're like, wait, are you covering something? Is this something that you're protecting? Because like they knew about my, so I was like, yeah. It's like, does that make you feel better to have your hand there? Yep. Okay. Like, keep your hand there. That was it. There was also a time that literally changed my life where I had a flare on my boob and it was red. It was not draining or anything. It was like where it was raised and painful, but not anything yet. Like where you probably couldn't even tell unless you're on the inside. And I said, oh, be careful, that hurts, to like a partner. And they stopped everything, like looked at me, and kissed my flare. I cried. It ruined the moment for different reasons because, but it was like, it was just an earth-shattering moment because it was a realization like, fuck, it's all in my head. It's mostly all in my head.
Okay, we got another question over here.
Yeah, hi Cassandra.
Hi, I was actually kind of nervous to ask anything because I'm perceived as, I mean, I know I'm younger than everyone here, but
19, y'all.
Mm-hmm. Yeah, so technically an adult, but also teenagers are also having sex, so. Yeah.
And intimacy is outside of sex. Intimacy can be before, after, it's still a conversation, absolutely.
Yeah, so I guess I kind of have some multifaceted, like, it's kind of multifaceted. Like, the first part was kind of like, sometimes it can be really difficult when you're younger to trust in another partner, especially because the maturity isn't there. And I've had experiences just seeing in high school and in college where people would make fun of other people's bodies that didn't even have HS, and people like they were saying things about them that, I don't know, I mean, I guess I'm just like, what advice would you give to people that are younger that are just scared because of how judgmental and kind of brutal other kids can be? And that's like kind of my first question. And my second question is, I have groin HS, and it always, like, there's always a sense of sadness for me because I want to be like warriors like Amani and Sid that can like show off their scars and feel confident and like do that. But I have it in such a sensitive area, and I want it to be like when people were in Times Square showing off their bodies like in the lingerie. But I know that if I ever decided to do that, people would be concerned because I look like a baby, which I don't know how to feel confident in that because I'm constantly told that I look like I'm 14, and that really hurts a lot. So I guess how would it's kind of thanks for like.
I get what you're saying. Like, growing up in Miami, kids are assholes, and I remember like I have a lot of guy friends, and so I was privy to their conversations and the way they talk about girls' bodies, right? They're comparing the color or the shade and the size of like their clitoris or their vulva, their labia, and these are like normal vulvas, and I'm like, oh my god, if they saw mine, what the hell would they say? But the experience that I had when I was a teenager and I was sexually active is that they also have no fucking experience, so they don't have anything to compare it to.
I know.
And so they don't know what the hell they're talking about. And so, like, again, like, not that I recommend what I did, but like, when I hooked up with people when I was younger, no one said anything because they didn't know what they're gonna compare it to, you know? So there's that, and also just like clothing sometimes, you know, like I didn't get fully naked. So all that's that, and you know, you can build better relationships even as a teenager and have partners that you trust. But even if you're doing it with partners that you didn't, like I had casual sex as a teenager. You know, we were just kind of like, we're not talking about it. I'm not gonna say anything. I'm not saying that. Okay, it's just that's what we're going, you know. And then, you know, as I got older and started, I enjoyed sex more when I was older, and I had full disclosure. I will tell you that. There was a sense of like, okay, I'm wanted, and that is being satisfied, so that's what I got when I was younger. But in terms of actually enjoying like sex physically and like orgasming happened later in life when I was full disclosure and having those conversations with my partner. So that's.
Yeah, sometimes I worry that because I constantly am I look and I'm told that I look very young, that I won't be taken seriously by a partner. And I also have a lot of abandonment trauma due to like my past, so it kind of coalesces sometimes into feeling like I'm not gonna be enough for people because I look so young. That like I'm scared that I won't be, and I also have a very peppy personality, that I won't be taken seriously.
Yeah, and that's, I mean, we all have stuff, right? And something that I realized, so like I grew up overweight, and so aside from having HS, I was also, you know, a larger bodied teenage girl in Miami, which is like the beauty standard's crazy. And my sister, who's 15 months older than me, is like skinny mini with a perky booty, was like a hot girl. And what's crazy one day is when we were on the beach, and this one girl was telling me how like she feels like no one takes her seriously because they only like she's never gonna live up to the standards, so she pushes people away because she's, you know, we're all sitting here picking ourselves apart, baby girl.
Even the people that are not in the HS room.
So it's not, you know, so it's not just you know, like. Beyond everything that Christina said, which is absolutely true, my only other advice to you, and I cried yesterday when you came up on the stage because I wish I had something like this when I was your age, because I hadn't even been diagnosed till I was 19. So I wish I had this community around me to build. My biggest advice to you is trust your gut and vet people, friends and partners. Just because you think someone's cute and you have good chemistry is not the end all be all. Is that person a good person? How do they treat other people? How do they treat the waiter when you guys are having dinner? How do they treat the person getting your car? How do they treat the neighbor on the bypass on the street? How do they treat their friends? How do you hear them on their phone? Vet people. And that will save you so much heartache as a woman in general, beyond HS. So like, I'm almost thankful about my HS in that way because it has forced me to be a better vetter of people and of partners. And the quality of partners that I've had as people have been incredible because I'm seeing who they are first. And get comfortable talking to your friends about it. Get comfortable talking to your family about it so that when it comes time to talk to a partner about it, you feel more comfortable and empowered. And yes, you look young. You're never, some people look old, some people look young. I can tell you're a serious woman. I can tell when you're on the stage. I can tell when you talk. I can tell by the way you carry yourself. You will be thankful for your baby face later. So just know that I know you know how to turn it on and that it's visible to everybody in the room when you turn that on. You can still be a warrior and advocate. You don't have to have like in social media acceptable flares. A lot of us have growing flares and we're still like advocates in different ways, and so you don't have to compare. Your journey can look different than someone else's, and it's still valid no matter what it looks like.
And please, if you can go to the next slide, the last slide. If, again, this is a short time, I want to answer all the questions, but Cassandra, this is my email, this is my Instagram. Come catch me outside and get my number. Like, if you want to meet in the bathroom and want me to show you more scars, if you want to trade sassy pictures because you're not ready to send them to a partner, like message me, text me, send me an email, send me an Instagram. This is the link to our HS and Intimacy Facebook group that I had with Christina where we were doing our calls At least it's a place to be a catch-all for us, for the group. Once we start developing anything else that we're gonna be moving on to with HS and intimacy, that'll be a good place to like get the information. So feel free to take a picture. Look, that's the heart bandage that I told you about. But thank you so much. Does anybody have any other questions?
I just wanted to say, think about the way that you, if Kennedy came to you for advice, what would you tell her, and then apply that to yourself? Because I think we often get stuck in our own heads and don't think about the way that we would tell other people to treat themselves.
I absolutely, and this sounds insane, but even in my house with HS and with other things, I often think about myself in the third person. I'm a very empathic person. I care very much about other people. I will pull my car over if I see someone crying in the street. I have pulled over for a lady I saw crying, walking down the street, and given her the flowers that I had bought for my house, and it turns out she had just given up a dog that she was fostering. We had like a 30-minute conversation on the street, okay? But for myself, it's harder to have that empathy sometimes with yourself. So trick yourself into it. Do a third person. What would I do for my friend Tati? How would I take care of my friend Tati? How do I feel about Tati's scars? How do I feel about Tati's pain? Like, think about yourself in the third person. I also want to do a little show and tell that I wanted to do if we had time, but because you approached this, 2 seconds. Oh, yes, please.
Yes, I'll make it quick. I just wanted to tell you also personally from a bigger sister perspective, I literally turned 30 this year, and it's supposed to be like my dirty, 30, flirty, but I just wanted to share with you, sometimes living with HS too, I have found myself, like when I was younger, my past about it being a sex-transmitted disease, or like my mom saying like, oh, maybe you're sexually active already, and that's the reason why you have these things happening in your grown area. It made me feel like scared to be able to speak about sex. It made me say like, those things are not good. Like, you don't do those things, or you don't watch porn, or, you know, it's very hard to also take myself there, if you know what I'm talking about. So I just wanted to tell you from an older perspective, sometimes society or what we learn in our past does not make it better. So it's not always a you problem, but I'm 30 and I'm still looking for my sexy moment. And like I said, it's really hard for me to believe like it's okay to do those things, you know? It's okay to enjoy those things because we're human, you know? So I just wanted to show you from a bigger sister perspective, people are mean, people make us think things that we're not supposed to think, but hopefully when you're 30 and you're my age, you are gonna be sexy, you are gonna be beautiful, and I'm gonna be looking forward for you to tell me all your stories, and I hope that I have some stories of my own to share with you.
Thank you so much for sharing. Thank you for being open about these things. It definitely changes with age, for sure. I encourage you to start practicing with yourself, like you said.
Next time we will give away
vibrators. So that's another homework assignment for all of you guys, to go home and touch yourselves. But seriously, and like you said, sometimes it's hard because like I'll touch a scar and it takes me, even myself, out of my body when I'm alone in my room. But take that moment, cry if you need to. Be gentle with yourself, cry about, mourn that feeling, mourn the feeling that you won't have the linear experience that we perceive other people to have, which isn't true either. But allow yourself to have those feelings. If you cry while masturbating, cry and try again. Like, bring yourself back. You know, practice with yourself.
Orgasms are anti-inflammatory, guys.
They absolutely are. I wanted to really quick show you a little tool that is available to you. I have them in my house. I've actually never used it, but I have it because I've always been I always think that if it was a scenario where I wanted to be intimate in this way and I didn't feel comfortable, that this was something that I could use with a partner I feel comfortable with. But it's a barrier method that is not used very common. But this is a dental dam. A lot of people have never seen these. These are used for oral sex mostly. It is really thin, super stretchy latex material. They come in with smells and flavors. This one is strawberry flavored and smelled. You could put it over an area, and it doesn't have anything to do with STDs, it doesn't have anything to do with anything, but it has to do with your own comfort. You know, they're gonna be smelling strawberries and not smelling or tasting or looking at anything else. You know what I mean? So I wanna pass this around if you guys wanna touch it, wanna see it, wanna get some, keep them at your house, play with it. I'm letting you know that there are many options for many things and that you can feel comfortable talking about them with me, even if you don't feel comfortable talking about them with anybody else. Do you guys wanna touch the dental dam? Smell it too, it smells good. Does anybody have any other questions? Another one in the back, Joanne.
We'll start here and go back. Hold on. Here.
Yes, hello.
Hi.
Hi.
I just wanted to say that with intimacy in HS, I was always super self-conscious because my scars are like in intimate places, if you will. So like literally last night I met up with a guy and half of the time they literally don't care because they're like, oh, you're so hot. Focus on being hot, guys.
Yes. Yeah.
You'll get there, I promise.
All right, hold on, one more.
That's literally what I wanted to piggyback off of. Man, you ladies have so many things that stand out about yourselves from your attitude, your knowledge, your beauty, your beautiful presence. Like guys we are shallow. Like sometimes we just like to have somebody in our presence, and that's not down in myself, but I'm just being honest. Yeah. The things y'all are concerned and worried about, we see you, we hear you, but we still coming. Like we gonna pull up. Like I just want y'all to know. So don't be, so down on yourself. Like I just want to encourage all the women in here today. So man, y'all are beautiful. Remember that, and have your sexy moment today.
Amen. There's also like, while watching porn is great and one of those things, I will say one of the things I didn't like about porn is that sometimes obviously the bodies that you see in traditional porn, and that can sometimes sometimes you see young men and their experiences, that's what they, so that's what they idolize, right? Like it's pink and it's whatever. And I'm like, nothing's pink. I don't know what you're talking about. Pink what? But anyways, I'm like, I remember did you see that TikTok video of that girl who was like, roast beef, and you remember that? And I always thought that was hilarious, because I'm like, yes, girl. Like, people need to talk about it. Like, bodies are different, right? And like the whole obsession with like everything needs to be like lighter and hyperpigmentation, and we're bleaching shit. Like, no one's bleaching their butthole. Calm down. So like, it is okay that like if things are different colors, like we are not Barbie latex dolls, So remember that. And their bodies, some areas are functional. Like, I don't think genitals, generally speaking, are like pretty organs anyway, but they feel good and they got that job and they do it. So like, that's okay. Thank you for doing your job.
Yes, absolutely. Anybody have any other questions?
Okay. All right. Thank you so much, Tati. That was awesome. Killed it.
Again, if you have any other questions, catch me outside.
Yeah, find out. So if anyone wants to just like stand up, shake it out a second, and then we're gonna roll right into a wonderful chat about one of our amazing partners who made this event possible. Without our partners, this would not be possible. So I am so excited to introduce Ann Fountain, who is with Novartis. Novartis has been a really great partner for us today. Not only did they help us make Empower possible, but they also partnered with us to make the Find Us campaign possible. That was all hands on deck. So everybody give Ann a warm welcome. You can use whichever one you want. Yeah, you talk really into the mic with that one.
All right, that's a hard act to follow. Yeah, thank you all. It's been an amazing day. I've learned so much. I've really had the pleasure of meeting many of you for the first time. My name, as mentioned, is Ann Fountain. I work in U.S. patient advocacy at Novartis here in the U.S., and really excited to be here and honored to be here with you all today. I was sharing with a few of you today that I've had the privilege of working alongside uh, you know, people living with HS for over 5 years now. And one thing I want to say, it's so truly incredible to see how this community has grown over these 5 years. It's just amazing. And that growth really is thanks to you, the passionate advocates, organizations like HS Connect, and leaders like Brinley, who are really moving the needle and making change. Today is really about all of you, your strength, your voice, and your journey. And empowerment starts with knowledge and community. And when you share your experience and advocate for yourselves, change happens. And I'm not talking just in treatment, I'm talking about how the world sees HS. At Novartis, we are really deeply committed to advocacy and advancing knowledge, improving treatment options, and fostering greater understanding of HS. And we are so fortunate we have all of you, amazing organizations to now work with to get the information out through. But most importantly, we're here to listen and to work side by you and partner with you as a trusting partner. We're proud to support HS Connect with events like this amazing Empower event. I hope we continue to see many of these over the years, and this grows and grows and grows. How many people did you have?
72 yesterday.
It's amazing, just amazing. And that's not even the virtual audience, so kudos to you, because it just keeps growing. Our commitment to HS is ongoing at Novartis. We're excited to what's coming ahead. There's lots coming forward with not just with the whole landscape. There's so much coming to this community. But I want to thank HS Connect and all of you. It's been an amazing day, and we're really honored to take this journey with you. So thank you all, and I'll let you know until next.
Okay, don't move because we have giveaways, and Andrew's gonna do the giveaways. Andrew? Hi. So we're gonna do the giveaways, so make sure you have your raffle tickets, and then afterwards you guys can, finally we're finishing the gift bags, and you guys can take your gift bags that are chock full of goodies, so. Okay, so Andrew.
Does everyone have a raffle ticket except Tatiana, whose number I know? Okay. Everyone hold.
I had one upstairs. She gave me no. I don't even see it. We got you. If 929, can you just say the last three numbers? Okay, 105, 105. Woo! Go D. All right, 089. Yay, Ashley! All right, 065. First speaker, yay, Whitney! 078. There you go, Jawan. 087. There you go, Aaron. 077. 077. 077. All right. 060. 060, no, 099. There you go. 064. 064. Okay. 090. 090. Damn, girl. 082. Yay, Kayla's mom. 074. 074. 086. 086. Yeah, Taylor. 100. 100. 100. Woo, Juliana. Full size Dermaleave. Get rid of that itch. 098. 098. Juliana one. 067. Huh? 067. Oh, shot it. Stop it. My kid keeps doing that. 059. 059. Over there. Woo! 070. Yeah, we have a prize winner over here. 083. Hey, Dimitri. 061. 061. No dice? All right. 010. 010. 063. 063. No? 080. Hey, Kayla. 088. 08. Hey, Aaron, number 2. 071. Remember, I'm calling. Yay, we got a winner. Remember, I'm doing the last 3 numbers of the little ticket thing. Okay. Hannah, we got a winner over here. Lucky enough. What you got? Do you want? Oh, Beautify HS, sure.
Beautified. 079. Hey, yeah, girl. Kayla just got lucky today. All right. 092. There you go. Go, Cassandra. Cassandra is the winner. I feel like 097. Did I not already call it? 097. Hey! 014. 014. 014. No? 091. 091. There you go, Tati. 075. 075. 073. 073. Hey. I feel like we're just going to get through all the tickets, so we should just give everybody something. I swear to God. Look. 096. 096. Again? Shut up. Did you win for real? Oh, hold on. Okay, good for you. All right. 016. 016. Okay, raise your hand if you have not won anything yet. 106. There you raise your hand. 106. There you go. 096. 096. There you go. Okay, 093. Okay, I have an idea. If you haven't gotten anything, raise your hand. Don't be shy. If you haven't won something, raise your hand. We have speakers, guys. Come on now. Don't be shy. All right, I'm going to keep calling numbers. 093. 093. 062. There you go. There you go. 102. 102. Hey, we got a winner over here. 102. 062. 062. 076. 076. Belinda. 068. 068. Okay. 085. 085. There you go, Taylor. 066. 066. 084. Hey, Dimitri. Okay. I'm literally going to go through every single ticket and we're going to still have stuff. So, like, maybe I'll just go get what you want. I don't know. 081. I swear to God, we have so much stuff. 081. Hey, we have another winner, Kayla's mom. 013. 013. There you go, Ali. Ali's a winner. 069. 069. 069. No? 072. 072. There you go. Another. 094. 094. No? Okay, I'm out of tickets and we still have prizes. So if you want something, ask for it. Love you. Bye. Also, look, I have an idea. We can make a line. Come get your gift bag and then go down and grab something from Hannah. So that's it, guys. This is day 2 is complete. Thank you so much. This was amazing. Grab your gift bag on the way out. You can stop by the corner over there and get a speaker. The gift bags are packed, y'all. Tux brought it. Thank you, Tux.